Good morning, everyone, and welcome to the January 23rd, 2024 Enforcement and Compounding Committee meeting. My name is Maria Serpa, chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I've advised the meeting moderator to allot 3 minutes to each individual providing comments. Through the meeting, at appropriate times, we will begin public comments for individuals attending in person in Sacramento, followed by public comment by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I'd like to ask staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. David?
When it's time to make a public comment, you will see a prompt on the screen similar to this. We will ask you to raise your hand. Computer users, you will find that hand at the bottom of your screen. Dial-in users will need to dial *3 to raise a hand. Mobile users, and I see a few of you out there, will need to find the correct screen. You have 3 of them, and only one of them has your hand button. I believe you can reach it by hitting the ellipses button, the ... As said before, you'll be given 3 minutes to speak with a 10-second warning. Thank you, Madam Chair.
Thank you. I'd now like to take a roll call to establish a quorum. Renee Barker.
Good morning, licensee member present.
Thank you. Indira Cameron Banks.
Good morning, public member present.
Thank you. Sung Oh.
Good morning, licensee member present.
Good morning. Nicole Tebow.
Good morning, licensee member present.
Great. Good morning, everyone. A quorum has been established. I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meeting at appropriate times. The committee respectfully requests that when comments are provided, they are done so in a professional manner consistent with how the committee conducts its business. The second item on the agenda is public comment for items not on the agenda or agenda items for future meetings. I now ask the moderator to open the line for individuals to provide public comment. You're not required to identify yourself, but may do so. I'd like to remind everyone that the committee cannot take action on these items except to decide whether to place them on a future agenda. Members, following the public comment for this agenda item, I will ask you on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, but rather an opportunity for members of the committee and members of the public to request consideration for items for future placement on an agenda. At that time, discussion will occur. Let's start with members in Sacramento. Is there any public comment in Sacramento?
Hi, yes, my name is Rhonda Collenborn and I'm from Pharmapod. Pharmapod hosts a medication safety incident reporting platform in 9,400 community pharmacies across the US, Canada, Ireland, and the UK, and we're about to launch in New Zealand and Australia. We currently represent over 350 community pharmacies right here in California, which is why I'm here today. We have extensive experience in the analysis of medication errors, providing feedback to pharmacies, as well as publishing articles based on aggregated de-identified data. We're the largest reporting system in Canada, representing more than 65.
I don't mean to interrupt you, but I think this is an agenda item. Is that correct?
No, ma'am. I'm actually going to be asking to present to the entire board at a later time. So it's just introducing us.
Corinne or Anne, is this an agenda item or should we continue with the public comment for agenda items?
I mean, from my perspective, I think it's fine for her to give her comments.
Okay, I'm sorry to interrupt you. I just wanted to make sure we had in the correct part of the agenda. I apologize. Go ahead.
That's okay. No worries. We are the largest reporting system platform in Canada, representing more than 65% of all community pharmacies across Canada. And we're the mandated reporting platform for over 5,000 community pharmacies in all of Ontario. Given our extensive experience in the analysis of medication errors in community pharmacies, I request the opportunity to discuss Pharmapod's platform at a future meeting.
Thank you.
Thank you.
I'm sorry for the interruption. Could you clarify, what is it called? Pharmacy Pod?
Pharmapod, Pharmapod.
Got it. Thank you so much.
No, my pleasure. Thank you.
Is there any public comment by individuals participating via WebEx?
We are now accepting public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We have a few hands raised now. If you're having trouble, you may type the word comment in the Q&A box, and we'll get to you as well. Starting with Melanie. Hold on just a moment, Melanie. We're going to send you a request to unmute your microphone. As a reminder, you'll be given 3 minutes to speak with a 10-second warning.
Committee members of the board, thank you for taking my public comments. My name is Melanie Horn, and I am a project manager and compounding coordinator for Sutter Health. And as a part of a future agenda item, I would respectfully ask if this committee would consider either something in the script or an FAQ regarding the position statement for the compounding regulation transition to USP chapters that are currently enforceable. Due to the current statement on the board website, there has been some confusion based on if we can move forward fully with the USP standards, or if we must also abide by the current California regulations that have been voted to be moved and transitioned and harmonized over. Since a comment in that statement states to comply with both federal and state regulations. And so I think that there's a little bit of confusion out there, and I'd love to be able to rest people's mind that the idea is that we start to fully transition to those new regulations. Thank you for the opportunity to make public comment, and I look forward to any clarification that the committee would be able to provide.
Thank you.
All right, next we're going to hear from Tara, followed by Shilda. Hold on just a moment. All right, Tara, we've sent you a request to unmute your microphone.
Thank you very much for the opportunity to make a public comment. I'm the director of the Alliance for Patient Medication Safety. We are also a PSO, a 501c3 nonprofit, and one of the first PSOs to be listed. We work with thousands of community pharmacies across the U.S. We have a lot of experience with the analysis of medication errors that occur in the outpatient setting, and work with our pharmacies on safe culture training, analytics of the data, and we assist with root cause analysis. Like others, like ISMP, we analyze pharmacy-related data collected from portals outside of the PSO and as part of the PSO. And I guess my request is to also be able to make a presentation at a later date. Thank you so much.
Thank you.
All right, next we're going to hear from Shida Guilak. Hold on just a moment. We're sending you a request to unmute your microphone.
Hi there. Thank you so much. I really appreciate being able to ask this question. I did come on yesterday to ask, and I was on the phone, and the prompts spoke over what the gentleman was saying, so I didn't hear what he had to say. But my question is in regards to ambulatory surgery centers and what the Board of Pharmacy, like how involved are they in the pharmaceutical services of ambulatory surgery centers, which are getting more and more in recent years because of cost of hospital stays. And it seems like there's more and more people are going towards that. And I go in there and do some consulting for them. I have found it to be the controlled substances are very loosely managed. And the few times that I go in, I find so many, we're going to be going in tomorrow to look at possibly some diversion by the anesthesiologist for the past several years, just the documentation and charting, continuously missing 50 micrograms of fentanyl, not showing wastage. Nurses, in the last couple years, I found some unlabeled syringes inside the OR rooms, and it seems like the pharmaceutical services, there's a lot of questions by people working in that area in ambulatory surgery centers, not knowing how to do the protocol or it just seems, and just another center I went into, the office manager was storing her fentanyl in her office instead of the double locked. She had 2 cases. She's like, oh well, we share the center with another doctor, so I just bring it up here, and she leaves her office. And I've just found some things that are just kind of blow me away with how loose it's been managed. And I was wondering, what is the Board of Pharmacy's role in helping to control that? And if there isn't any, is there a possibility of implementing something to have a third party come in and help with pharmaceutical services, and also audit charts and make sure, the diversion isn't happening with the nurses and the anesthesiologists, and that things are patient safety, all of it has been a concern. And so I wasn't sure where to go to. This last one, we're going to go in tomorrow, and I just can't believe the amount of discrepancies I'm finding and how loosely it's managed. And, the CEOs, he might have injected it as the patient was leaving the OR and just forgot to document, but on 17 charts. So I just didn't know where to go to. So I found out this was happening, and I came on to ask you guys for some support in how I can handle this and what we can do to possibly make it, get involved with them. And because here we are controlling retail pharmacy, and then the big drugs are being just loosely handled in these big centers. So it's a big concern on my end, and I just wanted to let you guys know and see what we could do.
Thank you for your comments. Unfortunately, this is not a question and answer period, but your comments will be used in our future agenda item that we have later today regarding surgery clinics. But for your specific questions, I encourage you and other members of the public to use the board's Ask the Inspector line to ask specific questions, and they can help point you to regulations that will help you. Thank you for your comment. Do we have other comments?
Yes, if I'm not sure, yesterday I was on the meeting and I was on the telephone call, but the prompt on the telephone call was speaking to me as the gentleman was telling me some of what his thoughts were. So I wasn't able to hear what he had to say, but I didn't know how I could get to that information. But as far as what you're saying is to call the Board of Pharmacy and ask the inspector about what Board of Pharmacy can do to get involved if they're not already, because I'm a little confused on that.
Yeah, the Board of Pharmacy has an Ask the Inspector email and phone line that will assist you in interpreting regulations.
Okay.
So I think that's all we can do to help you right now. Thank you.
Okay, thank you so
Do we have
much.
any further public comment?
Yes, next we're going to hear from Keith Yoshizuka. Hold on just a moment, Keith. We're going to send you a request to unmute your microphone.
Keith Yoshizuka. At the last full Board of Pharmacy meeting, I had requested an agenda item to establish a roster of frequently asked questions regarding adding of flavoring agents. And at that time, I believe that it was referred to this committee. So I didn't see it on today's agenda, but I would like to request it for a future agenda. Dr. Serpa, I think you had commented that you might be able to use the USP's FAQ regarding flavoring agents. I've searched the USP site and I couldn't find that FAQ listing. But I would ask that when the board develops theirs, that they keep in mind California specific laws, particularly BPC 4052.5, which allows the pharmacist to make changes in the form of the medication without necessarily contacting the prescriber. And so that I wanted to make sure that that gets addressed because one of the most common questions that I think is arising as a result of identifying and adhering to the USP standards, which now considers adding a flavoring agent as compounding, is whether or not the pharmacist can still add the flavoring agent without checking with the prescriber. Thank you very much.
Thank you, Dr. Yoshizuka. This is not supposed to be a question and answer period, but I will make one statement. I encourage you to look at the recent board alerts that were sent out and it will answer your question. Any other public comment?
We have no other requests for public comment at the moment. Do you wish to continue with the agenda?
Thank you. Members, we heard several comments regarding the current agenda items that are coming up on this meeting's agenda. So I think that we may have an opportunity to discuss those things there. You can see that there are members of the public that are very interested in the contract process and maybe participating in the contracting process for the entity for medication errors. That will also be discussed in a future agenda item at this meeting. But other than those things or other, actually I shouldn't say other than those things. Members, do you have any comments on the public comment about adding them to a future agenda?
Maria, it's Nicole. I just wanted to say I would be interested in the presentations from those who spoke up, or to at least make sure that they have the opportunity to be part of the process. Thank you.
Thank you, Nicole. Just to be clear, maybe I didn't explain it very well. The process that we're going to be discussing in a future agenda item on this meeting is the contracting process, and those interested in contracting with the state will have an opportunity to present their information in the format that we decide at the next agenda item. So we won't be able, my preference is that this committee not listen to every contracted, every company that wants to contract with the state, but that we use the contracting process that we're going to discuss in the agenda item. We can also discuss it there if you think that's not correct. How's that?
Yeah, that's perfect. That actually answers my question. Thank you.
Thank you. I'm sorry, we're not supposed to have discussion. I felt like we needed to kind of clarify that, but thank you, Nicole. Any other members' comments about adding things to a future agenda? Okay, great. Thank you. Let's move on to agenda item 3, approval of draft minutes from the October 19th, 2023 committee meeting. Members, attachment 1 includes a copy of the draft minutes from the October 19th, 2023 meeting. Do you have any questions or comments on the draft minutes? I would also entertain a motion should you believe such action is appropriate.
Chair Serpa, I make a motion to approve.
Thank you, President O. Do we have a second?
This is Renee. I'll second.
Thank you, Renee. With the motion and second on the floor, I now open discussion for public comment on the draft minutes. Are there any members in Sacramento that have comments on the minutes? Excuse me, any members of the public?
There's no members coming to the public comment table.
Thank you. We're ready for public comment for individuals participating via WebEx.
We are now accepting public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Please, thank you. Since there's no public comment, we'll continue with the roll call vote. Renee Barker,
Yes.
Indira Cameron Banks,
Yes.
Sung Oh,
Yes.
Sung, are you on mute?
Oh, did it? Yes.
Thank you. Nicole Tebow,
Yes.
and I vote yes, motion passes. Thank you. The next agenda item 4 is presentation on the Canadian Medication Incident Reporting and Prevention System, CMIRPS, by ISMP Canada. Members, as you recall, as a part of our discussion on the implementation activities for Assembly Bill 1286 during our October meeting, we decided it was appropriate to receive presentations from entities that currently receive and review medication errors. I'm pleased to welcome several individuals from ISMP Canada. I'm not sure if they've all been promoted. Oh, it looks like some people have been promoted during our earlier discussion. So I'd like to welcome members from ISMP Canada. That includes Ina Adjula, Sylvia Hand, Melissa Sheldrick, and Carolyn Hoffman. Thank you very much for your time today and coming to our meeting. Unfortunately, you didn't get to travel to California, but we appreciate seeing you virtually to share your experiences with implementing and operating a medication reporting system. Thank you. You can now begin.
Thank you very much. It's Carolyn Hoffman, and I'm the CEO for ISMP Canada. And as the slides are coming up, I will just check to make sure that Melissa, if we do a check and make sure you're able to speak, and Ina and Sylvia, and then we'll be set to proceed.
Yes,
Melissa.
I'm good to go. Yep.
Thank you. And Sylvia Highland and Ina.
I'm good to go.
Great. And just checking on Sylvia, and maybe we will be able to proceed as Sylvia gets in and being able to speak. It is a great pleasure to come speak to the California State Board of Pharmacy on community pharmacy medication incident reporting in Canada. I'll open with our land acknowledgement on the next slide. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. I have a session overview to let you know what to expect during our brief presentation. And we'll open with Melissa Sheldrick's story. We'll talk a little bit about what medication incidents are and the work at ISMP Canada. And we'll spend most of the time talking about reporting, learning, and acting on medication incidents, how each pharmacy contributes to their incident data to the National Incident Data Repository that ISMP Canada hosts, and then a few examples briefly with the time that we have. So let's begin with Melissa Sheldrick's story. Right after I highlight the 4 speakers, and here you can see our pictures and our titles with the organization. And over to you, Melissa.
Thank you, Carolyn. Hello, everybody. Thank you for having us here. My name is Melissa Sheldrick, and I'm the Patient and Family Advisor at ISMP Canada. And I come into this world of medication safety after the tragic loss of my little boy, Andrew, to a medication error in 2016. Andrew was 8 years old at the time. He was on a prescribed dose of tryptophan for a sleep disorder every day. He took it before bed. The tablets was not sustainable for him to take them. We had to crush them. They were quite large. And so we had it made into a liquid compound for him, which was really just the answer that we needed. And we refilled it every 2 weeks, and we did that for about 18 months until we picked up a refill in March. And I gave him 1 dose of that new refill and put him to bed, and he didn't wake in the morning. And it wasn't for some time after that, about 4.5 months, that we even knew what happened. We were told that the medication that was in Andrew's liquid in his bottle was not tryptophan. It was filled with baclofen mixed in the same concentration as his tryptophan, which equaled 3 times the lethal dose for an adult. So this started me on a journey of learning and wondering what was going to come of this. How could we make improvements? That this was not supposed to happen to any family. It was entirely preventable. And what was my role to be able to move that work forward? So I find my self at ISMP Canada and the work that we do together to improve not only medication incident reporting and learning, but also sharing of the information and helping people and patients and families and organizations and regulators to support that and help them also to prevent medication errors from happening.
Thank you, Melissa, very much for sharing that and helping us to know why medication incident reporting and learning is so important. What is a medication incident? We have a very simple definition here. There are more complex definitions, but to ground us all, we say very simply, it's a mistake with medicine or a problem that could cause a mistake with medicine. And on the next slide, you see one example of many in the literature around the extent of preventable harm that is occurring relating to medications. And here we've drawn from the OECD recent 2022 reports of the economics of medication safety, and Canada and the US and many other countries are part of the OECD. And 1 in 10 hospitalizations may be caused by a med-related event. As many as 1 in 5 inpatients experience medication-related harms during hospitalizations. An estimate of at least 54 billion American dollars being attributed to cost from avoidable admissions due to medication-related events and added length of stay due to the harm that's going on in the hospitals. Now, this is looking very much at hospitals and inpatients where it's easier to find data and to be able to cost that out. We know that this issue begins and ends and is in the community as well in many other settings. So on the next slide, you see our mandate. ISMP Canada for over 20 years has been a trusted partner to work with many across Canada and globally to strengthen medication safety through timely learning, sharing, and acting. And I want to really emphasize that ISMP Canada is pan-Canadian or national. The independent aspect of ISMP Canada is so important. We are a not-for-profit. We are primarily funded by various governments in Canada, right now primarily by Health Canada to do our work. We take very limited dollars from any industry, and if we do so, it's always unrestricted, and we're very transparent by that. This is very important. We need to know that this is the level of rigor, this is the perspective on medication safety when we're working in such an important area. The cycle here, learn, share, act. We'll start with learn. That's where we get these reports in, collecting, aggregating them and analyzing them. And then from that, developing the actionable evidence-informed recommendations. It's community pharmacy, but it's also all across the sector. Today, we're going to focus primarily on community pharmacy in our examples and our discussions, but we are all across the sector. We are able to leverage learning from reports that come all across where healthcare is delivered. And then we partner up to act. We don't just send those recommendations out. We work with many sectors to actually improve medication safety with the knowledge gained from medication incident reporting. And on the next slide then, over to Sylvia for a little bit about the structure in Canada.
Thank you, Carolyn. I will provide a brief overview of the national program called the Canadian Medication Incident Reporting and Prevention System, often referred to as CMIRPS. And if we go to the next slide, this slide provides an overview of the steps in our collaboration with reporters and partners to respond to medication incidents. So following identification of an incident, there are mechanisms for reporting into the program by healthcare organizations, individual practitioners, and consumers. ISP Canada provides review and analysis and trend identification for the data received. We share learning through bulletins and alerts and communications. And we also work with partners to facilitate improvements in medication use systems and practices, like Carolyn says, to take action on what we're learning. And if we go to the next slide, we see a schematic of the Canadian Medication Incident Reporting and Prevention System. It is a collaborative program funded by Health Canada. And this schematic shows the different reporting channels at the top for receiving incidents. And so the Canadian Institute for Health Information, one of our partners, collects reports from hospitals and long-term care. ISP Canada receives reports from practitioners, consumers, and community pharmacies. Our partners include Healthcare Excellence Canada and Patients for Patient Safety Canada as collaborating parties, and ultimately action is taken collaboratively for the ultimate aim of safer products and care. As Carolyn mentioned, the program is funded by Health Canada. And if we go to the next slide, the Community Pharmacy Data Repository is the National Incident Data Repository for community pharmacies, and this is a component of the CMIRPS program. And if we go to the next slide, I'll tell you that these are some details around our National Incident Data Repository. You'll hear more in this presentation for community pharmacies. The key points on this slide is that it's a component of CMIRPS. Incidents, reports of incidents are submitted anonymously by community pharmacies. Pharmacies use a reporting platform that meets provincial regulator requirements. And the data is then submitted through an application program interface into the National Data Repository. And ultimately, the shared learning contributes to improvements in community practices and informs research and policy. Thank you. Over to, I think, Melissa.
Thanks, Sylvia. When we learned that Andrew's death was due to medication errors, one of my main concerns, like I said, was that there was going to be no learning that was going to come of it. So I started researching about how does error reporting happen in Canada? What does it look like? What is the landscape like? And what I discovered was that only that small province of Nova Scotia on the East Coast had a mandatory continuous quality improvement program that included anonymous error reporting. It's important to consider not only the error reporting piece, but the continuous quality improvement piece. And so when I learned about their program, I started to advocate for these types of programs across the country. In Canada, healthcare is a provincial jurisdiction, so I started going province by province, starting in my own province of Ontario. And so I met with the regulator of the Ontario College of Pharmacists here in Ontario, and together we created the AIMS program. So it's called Assurance and Improvement in Medication Safety, and it's a standardized medication safety program that includes anonymous error reporting. And those 4 pillars that you see at the bottom are really critical in any continuous quality improvement program, to be able to learn as much as possible and then do the analysis and share back the recommendations and the actions that can be taken to improve the safety of medications. I also like to tell you that the A and the S are Andrew's initials, and so this is really a tribute to his legacy. So once I started going province to province, and in parallel, ISMP Canada was doing this work. And then when I joined the organization, we were doing this together. And now in 2024, we have 6 provinces with these programs in place. We have Newfoundland and Labrador on the East Coast who are coming on this year. And it's important to note that all of the regulators are considering these kinds of programs and understand the value and the importance of them and are moving towards them. Over to Ina.
Great. Thank you, Melissa. So as Melissa mentioned, the journey began with Nova Scotia in 2010. Currently, as she said, there are 6 provinces in Canada requiring mandatory incident reporting. 5 of these provinces currently report into the National Incident Data Repository as a part of the CMIRPS program, thus contributing to the national landscape. And as Melissa said, Newfoundland and Labrador will be the 6th province contributing to the NIDR starting July 1st, 2024. It is important to note the variation across the provinces regarding the platform providers. 2 provinces have 1 platform provider designated for reporting, while the other 5 provinces allow any reporting platform that meets the requirements to submit from that province. The National Association of Pharmacy Regulatory Authorities, or NAPRA, is an alliance of the Canadian Pharmacy Regulatory Authorities. This organization facilitates collaboration for its members to discuss and take a national approach in addressing common issues in the practice of pharmacy in Canada. They agree that provincial medication incident reporting programs contribute to continuous quality improvement and patient safety to all people who live in Canada. In fact, as a result of some follow-up work that we have done with regards to labeling safety of active pharmaceutical ingredients, NAPRA added one of our recommendations to their master formulation template. An important piece of the implementation process for each province has been answering the question, why is it important that I as a pharmacist report medication incidents into a designated database and into a national database through language in their standards or quality assurance programs? Each province has endeavored to answer this question, why? With these 2 slides, we have shared each province's approach. Safety expert James Reason argued that the most detrimental error is failing to learn from an error. With this approach, we learn from each other. Next. And one more, please, Melissa. Thank you. Now we'll talk a little bit about how each pharmacy contributes to the NIDR. ISMP Canada works with any reporting platform provider to submit anonymous near misses and medication incident data from community pharmacies into the NIDR. As noted earlier, the Community Pharmacy Incident Reporting Tool was the first medication reporting platform in Canada, developed in 2008 as part of a research grant. It's still very widely used today. In-house reporting programs can also be developed for corporate pharmacy chains to report into the NIDR. Community pharmacies can also use third-party platform providers to submit their reports of incidents into the NIDR through an application programming interface. This graphic helps illustrate the 2 possible pathways for a community pharmacy to report into the NIDR. Community Pharmacy A wishes to use the Community Pharmacy Incident Reporting Platform, or CPHR, to report medication incidents and near misses. A data sharing agreement is signed between the data owner, which can be the individual pharmacy or a corporate pharmacy chain, and the NIDR, which is housed by ISMP Canada. The chosen reporting platform provider is named in the data sharing agreement, and data is collected through a secure transfer protocol for the purposes of analysis and shared learning. Community Pharmacy B also wishes to report into the NIDR and chooses another platform provider of their choice. The same steps apply here as well. A data sharing agreement is signed between the data owner and the NIDR, and pursuant to a data share agreement being received from Pharmacy B, a data submission protocol agreement is signed between the platform provider and ISMP Canada. This DSPA provides the application programming interface, terms for use, and includes a data mapping table. Overall, the pathway is the same for Pharmacy A and Pharmacy B. Both have signed a data sharing agreement, and both pharmacies have selected a platform provider that meets the regulator's requirements and submits data into the NIDR. The platform provider for Pharmacy B has one extra step, which is the signing of the data submission protocol agreement between the platform provider and ISMP Canada. Learning from both pharmacies will contribute to the provincial and national NIDR analysis outputs. So just a quick look at the summary of steps for a community pharmacy. We have tried to keep this as easy and painless as possible, recognizing the workload for community pharmacists. A pharmacy must choose the medication incident reporting platform, which exports de-identified anonymous data to the NIDR, which meets also the regulatory body's platform criteria. The pharmacy manager, owner, or corporate office then signs a data sharing agreement with the NIDR, authorizing that platform provider to submit anonymous reports. The next step has been province specific. Some provinces have wanted to receive the information directly from pharmacy, declaring to the regulatory body their choice of a reporting platform provider. Other provinces have chosen not to receive this information, but rather simply a declaration that the process has been completed, or there are checks and balances that occur as part of the inspection or audit process for that province. There are also different types of fees to be managed by the pharmacy. There is a regular subscription fee to the platform provider, and there is also an annual data processing fee to ISMP Canada, which covers proportional costs associated with items like data transfer, data review, and validation. The pharmacy can then begin reporting both medication incidents and reports of near-miss events. As a part of their CQI process, the pharmacy will conduct a retrospective analysis through either individual incident analysis or a multi-incident analysis. There is also a prospective approach to CQI, which is the medication safety self-assessment, which we will speak about in a later slide. So what does the pharmacy report? There are 7 mandatory fields to report into the NIDR: the date, the type of incident, who the incident was discovered by, not the name of the individual, but their role within the process, the medication system stage involved. If the incident involved a medication, the name of the medication is mandatory, the degree of harm to the patient, and also a free text field to help the reporter provide any relevant details they feel are pertinent to contribute to lessons learned. Mandatory fields may be combined with optional fields to accommodate reporting platform fields that are not available in the NIDR dataset. There are also optional fields in the NIDR. The more information received, the more valuable the analysis will be for shared learning. Some key optional fields include contributing factors and incident background information. Reporters have the ability to add more details in free text fields which describe the actions taken at the pharmacy level, and also any learnings they would like to share. And back to Carolyn.
Thank you, Ina. At ISMP Canada and indeed around the world, we know the successful implementation, use, and growth of medication incident reporting systems relies on thoughtful, focused, and very much a collaborative data analysis, and developing shared learning from that data analysis and providing some kind of meaningful practice support, meaningful insights for improving safety at the front line. We've got some examples to show you. The first is our process at a higher level on the next slide. And here you can see that what happens as the reports come in from the community pharmacies, and as well ISMP Canada accesses or gets different reports from across the sector. We have a multidisciplinary analysis team, highly expert in this area. Some of the individuals with 15 or more years experience in doing this. Yes, a standardized tool is important, which we have to do this, the Canadian Incident Analysis Framework, and our own methodologies and approaches to have pharmacists, nurses, doctors, patient and family advisors, and other experts look at a coordinated way at analyzing that data. And from that, we make the outputs. And here we have alerts, bulletins, practice improvement tools, and support for knowledge translation in a wide variety of ways across the country. And so as we advance on the next slide, you do see that we wanted to show you one slice, one kind of quick overview of reflection on the data. And we do have a publication, ISMP Canada staff and other partners from other organizations in Nova Scotia collaborated to issue the quality related events reported by community pharmacies in Nova Scotia over a 7-year period, a descriptive analysis in 2018. And this can be found in CMAJ Open Access. And you have a link here, and we'll share the slides. And so at a quick glance here, what does this mean as of 2018? 301 community pharmacies over that time period submitted just over 98,000 quality related events, very similar to what we've been talking about for medication incident definitions. 0.95% or 928 were associated with patient harm. Thankfully, what we're seeing with the reporting is, the majority is near miss or no harm. The near miss would be it never did reach the patient. The no harm is it did reach the patient, but no harm was experienced. That is the vast majority, but you can see even in a small province like Nova Scotia, there are very important reports related to harm. And the most common types of quality related events overall that were reported were incorrect dose or frequency, incorrect quantity, and incorrect drug. Most of the quality related events overall were from the order entry phase in the pharmacies. And really important to know that there are key differences in the types of reports from community pharmacies and those from other settings. That's why it's so important to get those reports in to know what's happening right at the community pharmacy. And on the next slide, then, we move to some examples further about this data reports quantitative reporting. And over to, I believe, Ina on that, or Sylvia.
I can
Sylvia.
quickly describe the slide. So these are two examples of how we share information back with community pharmacies in participating provinces. On the left is a safety brief. It provides provincial specific data, and then tips or recommendations for community pharmacies. And on the right is what we call a national snapshot. We do this annually, and we focus on a data subset or emerging issue and a specific data analysis, and we share back that learning. And if we go to the next slide, we do regular evaluative work, including with third parties, to identify results from the program and impact from the collaborative work at local, provincial, and national levels. And to date, there have been over 200 standards, guidelines, and best practices that have been influenced by ISP Canada incident analyses and recommendations. And to give, two examples, all nurses and pharmacists working in hospitals are required to follow the medication safety standard or required organizational practices, and these were developed with input from ISP Canada. And to date, we have received more than 374,000 reports of medication incidents, and this is important for us to continuously measure and monitor for identifying that there is sustained interest and growing interest actually in sharing reports for learning and shared learning across the country. And I think we can go to the next slide. This is a hospital example. It's an example of collaborative work that was done in Canadian hospitals following reports of fatal errors with neuromuscular blocking agents. And on the left was a label changes made by one company, and then working with all of the manufacturers in Canada, we can now say, and working together with our regulators as well, Health Canada in particular, that all products that are neuromuscular blocking agents now have a warning paralyzing agent on the ferrulin cap. And evaluation work that's been done has demonstrated that through the increased awareness, the product improvements, and as well as practice improvements in hospital, there's been increased safety with these drugs. And I think over to Melissa.
Sylvia, one of our most widely disseminated outputs is our safety bulletins. And these are reports that are written for healthcare providers. Typically, they're based on errors that have been reported to us. This particular one is based on the incident analysis that was done on Andrew's case in 2017 and 2016. And in these safety bulletins are not only the case descriptions, but also the contributing factors. We know that there are usually many contributing factors. What's really important in the safety bulletins are the actionable recommendations for multiple stakeholders that stakeholders can take and begin to look at how they can implement it in their own space and setting. These are available on our website for free, so you can, there's a link here to this one, but you could go on ismpcanada.ca and have a look at all of them. One of the important things that ISMP Canada works on is continuously improving. And so earlier, Ina mentioned the NAPRA standards that were changed based on the labeling work that we did for active pharmaceutical ingredients for pharmacy compounding. And this actually stemmed from the incident analysis from Andrew's case. So that was the beginning of it. And then over the past few years, we have been working to improve parts of it, and one of those parts was improving the labeling. We also have a consumer part of ISMP Canada called safemedicationuse.ca, and we have consumer newsletters that we publish for the public to help them stay safe with their medications. We provide safety tips for them and help them learn how to be part of their safety journey with medications. And over to Ina.
Thanks, Melissa. The medication safety self-assessment is developed from the analysis of reported incidents into the NIDR. This medication safety self-assessment for community pharmacy is used by a pharmacy to self-assess their medication management process, to develop safety action plans, and to implement QI strategies. Overall, to evaluate their progress towards medication without harm. And we have a few other supports for community pharmacists. If we could go to the next slide. ISMP Canada's e-learning portal provides online education modules to advance patient safety, all informed from the data collected from reporters. These interactive courses can be taken anytime, anywhere from a computer with an internet connection. And finally, we also provide many learning opportunities through workshops, all designed for participants to make better use of their reporting, learning, and quality improvement programs.
As you can see, we at ISMP Canada are passionate about community pharmacy reporting, learning, sharing, and acting to reduce preventable harm. We have extensive experience in this area, and as you've seen, there is change that can happen. We would like to acknowledge this important work underway at the California State Board of Pharmacy and how important it is to move this forward. And we look forward to staying in touch and sharing and learning in the future with you. Thank you very much.
Thank you very much for the excellent presentation and great information. I believe this is very helpful to the board as we continue our efforts to implement the mandatory medication error reporting. Members, do you have any comments or questions for the presenters? I can't see your hands. I'm sorry. If you speak up, that's okay.
Hi, Hi, this is Renee Barker. Thank you so much for the very thorough presentation, and I I do want to say to Melissa that I'm, I know it's been a few years, but still my condolences to you at the loss of your son over compounding error. So I certainly am glad that we are embarking on this if it can, in the future help prevent more. I did want to ask, I had found a document, it was from 2022, it says evaluation of ISMP. And this, they had some recommendations. And so when you were kind of mentioning at the very end there about how the safety bulletin, I know there's one that goes to healthcare providers, so that's great and that needs to happen. And then there's the safety bulletin tips for parents. And then this is just sort of a, obviously for fact finding for us, because as we kind of look forward to setting this up and being consumer protection, in the recommendations, it talked about needs to increase the consideration of diversity and inclusivity in its activities. And then, that it may, just its safety bulletin may potentially affect one population more than another. Anyway, I'm just wondering if there was, if you can speak to that a little bit, because wondering like for this one, how is this for parents, for the public distributed? Do people opt in? Is it only available online? And is there any other, since then, any other changes or directions that you can speak about? And especially for people who have, different language learners, I think there's most likely other languages being spoken. So, just again, for the safety of the public, if there's any response to that. Thank you.
Yes, I'd be happy to start off and then invite Melissa and others to comment on this. A very important question, and recognition in the evaluation that ISMP Canada has a significant impact, that's clear. But with the diverse population in Canada, are we reaching everyone that we should with this work? And then are we learning from everyone what their reports are, what their issues are? And the board recognized with the latest strategic planning cycle that we went through, which is now 2.5, 3 years ago, the board recognized this would be a strategic objective, strategic priority to advance, is focusing on greater diversity, inclusivity. And so we have taken a number of steps. And for our purposes today, it would be good for you to know that the newsletter that you talked about, so you're talking about a consumer newsletter, it relies on signing up for it to automatically get it, or finding it on our website, or seeing it on social media. It does by nature not reach everyone, sadly, that it needs to. And so Melissa, and I'll go here to Melissa. Melissa's leading some very important work to engage further with the diverse populations in Canada. What do they need and how would they receive it best? Over to you, Melissa.
Thank you. We are looking to expand our consumer audience for those exact reasons. And, finding out what is it that the public wants to and needs to know about medication safety. I will speak for myself and say that before all of this happened, I was very naive to the risks with medication. And so we want to make sure that we are being able to put real evidence-based information into the hands of Canadians so that they can take that important role with their medications. The other thing is that we want to, we are in the process of updating our consumer website. So to be able to build that according to the needs of Canadians will be very important, and engaging them to help us do that. The co-design method is really important for work like this, because the lived experience and the perspective of consumers is key to developing something that will be authentic and will be useful and sustainable. So that's one important piece. And the consumer newsletters are, right now they're published in English and French. Those are our two official languages. They are written in plain language for consumers. They are reviewed by consumers, patients and families, which is a really important piece of that as well. So we are working on expanding our consumer reach. Our social media following is growing all the time. And so we welcome you to have a look at our consumer website, safemedicationuse.ca. You can sign up for the newsletters. They will come directly into your inbox, and there's lots of excellent information in there.
Yeah, thank you so much. Appreciate it. Thanks for all your good work.
Any
Hi,
further
this is
questions?
Tom. Wanted
Go
to
ahead.
say thank you for coming. I really appreciate your time. Thank you for coming, everyone.
Any other comments from members? Thank you. As a public agency, the board is required to accept public comment on each agenda item, including presentations. Public comment is not intended to be a question and answer session, but rather provide members of the public an opportunity to comment on the information provided. You're welcome to answer a question if the presenters. You're welcome to answer the question if you choose, but you're under no obligation to do so. Are there any public comment in Sacramento?
No one is approaching the public comment table.
Thank you. Moderator, we're ready for public comment from individuals participating via WebEx.
We are now accepting public comment on the presentation via WebEx. If you'd like to make a comment, please raise that hand by tapping the hand button at the bottom of your screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. If you're having trouble finding that hand button, we have the Q&A box in the lower right-hand corner of the screen where you may type your comment or type the word comment to make your request. And our first request comes from Paige Talley. Hold on just a moment. We're going to send you a request to unmute your microphone. As a reminder, you'll be given 3 minutes to speak with a 10-second warning.
Representing the California Council for the Advancement of Pharmacy, and there was mention of fees being paid to NIDR for processing, but there was no mention of how much those fees are. So I would like to know if you can answer that. What the cost is.
Yes, we can. This information is publicly available off our website, so we can. And I'll just check. Ina or Sylvia, would you like to provide the information?
Sure, I could answer that question. The fee to the NIDR is an annual cost of $70 plus tax.
Okay, can I ask another question?
You have 3
You
minutes.
have 2 minutes left.
All right, thank you. There was also a transaction fee mentioned, and what is that?
There were 2 fees mentioned. One was the NIDR fee, which is the $70 I just mentioned, and the other is a fee to the platform provider, and those costs are specific to the platform providers.
All right, thank you.
And I'll just follow up to be clear that what ISMP Canada receives is the $70 for the actual data intake, the data infrastructure, and it's a partial cost recovery. We do receive some funding from Health Canada for this, and we want to acknowledge Health Canada funding for sure. It's very important. And then the $70 comes to ISMP Canada for the additional costs that are related to that. The platform is completely separate. The pharmacies can choose to use the CFR platform we provide or a different one, and those costs are then obviously different than the cost for the NIDR. So I just want to make sure that that's clear.
Okay, thank you. And the transaction fee is per transaction, correct?
No, and I'm not sure transaction would be the right term. I'm not sure where So the software platform cost, and Ina, I'll get you to jump back in here and we'll make sure we've got this clear. So the NIDR costs $70. The software platform is whatever the software platform charges. And that would be then separate. And we don't have any per transaction fees at all. So Ina, I'm just making sure I'm stating that correctly.
That is correct. It's an annual cost. There is nothing that is per transaction.
That's the $70 fee, right?
10 seconds.
The
Okay,
NIDR costs are $70.
but the
And
platforms are per transaction.
no transaction fee. Actually, there's no charge to the platforms to submit to the NIDR. There's no charge by ISMP Canada to the platforms to submit to the NIDR.
All right, thank you.
Thank you. Next, we're going to hear from Kathy Gomeshi. Hold on just a moment. We're going to send you a request to unmute your microphone.
Officer at an academic medical center. I wanted to thank you all for the really great presentation and overview of how you, well, the story of why this is important and the structure and processes that you have utilized to encourage learning from medication errors so that we hopefully don't have to continue to repeat them. I did want to comment, or I guess ask, it was interesting to note how the different provinces had different styles of implementing this. And I was just curious if there was any comments or feedback about if any organizations previous to this had existing error reporting to a patient safety organization, or if this was sort of the first implemented in Canada. I partially ask that because as part of health systems, we may have community pharmacies in many health systems, and some community pharmacies in California are currently reporting medication errors to patient safety organizations and have, you know, that de-identification and forming the data to, you know, fields that can be shared. And so I was just curious if there was any feedback or commentary from ISMP Canada regarding that process.
Thank you very much for the question. I'll start off and then I'll ask the team if they want to jump in. So if I understand correctly, you're asking about were there any other reporting programs in Canada other than what we've talked about today? And yes, there is for hospitals, for long-term care organizations, a number of different structures in place across Canada that are also reporting. And we highlighted briefly how we get access into looking at some of that data in Canada with our partner, the Canadian Institute for Health Information. So but there are many organizations in Canada with reporting systems in place. We see part of them. We see part of the data from that. So I'll just check with anybody else on the team. Do you want to jump in with additional comment?
I'm just going to jump in, Carolyn. I also wanted to mention that we receive error reports from consumers as well. Consumers are the constant with their medications, and the information that they send us is very important and it's very valuable. So that's another important way that we learn about medication issues and risks across the country.
And that looks like that's it from our team on that one.
All right. Thank you, everyone. We're going to make one last look around to make sure that we've captured everyone's request. Stephen Gray, hold on just a moment. We're going to send you a request to unmute your microphone. All right, Stephen Gray, we've sent you one request. We're going to send you a second request to unmute your microphone. Hello, go ahead, please.
Thank you. I apologize if this is already asked and answered or presented. In California for years, there has been a concern about access to this database of error information. Access by news agencies on the detail, access by plaintiffs' attorneys to get general information to add to their case. To what extent is the information that you collect through your system protected from such access as a way of encouraging reporting, I guess? I don't think you mentioned that. So, what access would others have? News agencies, plaintiffs' attorneys, other regulatory agencies to this data?
I'm sorry, you're muted, Carolyn.
Let's try that again. I'm going to start off and then I'll ask Sylvia as our privacy officer at ISMP Canada to comment. So first of all, it's very important that we reinforce the anonymous nature of this data that we're talking about. So what we're collecting in IDR is by definition to be anonymous, and therefore we would have no way of knowing the patient specifically in a report and then be able to respond to any kind of legal request. We're very clear it's anonymous. We're very clear that not speaking in any way that might identify a reporter should for some reason we have that information. We have very clear and specific policies and procedures and data sharing agreements that talk about the fact that we don't share that information. In Canada, we have no legislative pan-Canadian structure for having privilege, quote, legal privilege, as you do with PSOs in the US. That does not exist on a pan-Canadian way, but certainly it does provincially, and each of our provinces and territories do have their unique legal structures that they can access to claim privilege if they're looking at a particular incident. And so at this point, we feel that we have a strong reputation and we have never had to release anything. We've never been asked officially, to my knowledge, to release anything. And so this is not a concern at this time because of the real strong and clear setup and operation of these processes and procedures. And that's under Sylvia's leadership. So Sylvia, additional comments before we check with the rest of the team?
No, I have nothing to add other than that if we do get a request, we encourage the family, patient, anyone who needs information to work with the source where the incident may have occurred. And for all the reasons that Carolyn mentioned, that the data we have is anonymous, de-identified, and that we're not able to help in that way that they need help. So we encourage them to work with their organization and their context there.
Pardon me for interrupting, but what I'm concerned about, or what's been the concern, I understand privacy of patients and privacy of pharmacists, but can a plaintiff's attorney go in and get reports about all the errors made by a particular pharmacy or a particular hospital? That's been the biggest concern, was that they go after that. So to what extent are pharmacies and hospitals protected?
So in our database, we do not know the source of the pharmacy. So it goes through an API and it's anonymous. So we only have the data in its de-identified form for analysis. We do not have the name of the pharmacy.
We only know the province that it's from, and we also would know if it came from a third-party platform. We would know that, but none of the data that flows in, as Sylvia is saying, we know the province platform, but no particular pharmacy to respond to these kind of requests. And to date, there's been no concerns with that in Canada. It is a very different dynamic in Canada regarding litigation, and that's important for you to know, to have the different context. We know it's a much different circumstance in the US regarding this, but in Canada, no issue with this to date, no issue with this.
All right. Thank you very much, everyone. I'm sorry, Stephen, but your time ran out in the middle of that. We're going to take one last look around, but I think that's everybody. All right, that's it for our request for public comment. Do you wish to continue with the agenda?
Yes, thank you. Bringing the discussion back to members, do you have any final thoughts, members? I can't see your hands, so speak up, but I don't think there are any final thoughts. I wanted to thank all of our presenters again. You've been very generous with your time, and I truly appreciate all the valuable information you provided. This information will be invaluable to us as we continue our journey in implementing AB 1286. Thank you again for your time and have a great day.
Thank you.
Members, our next presentation will be probably about 20 minutes, and after that we'll take a 15-minute break. But I just wanted to do a pulse check and see if you needed a 5-minute break at this point, but we still will be taking a 15-minute break after the next agenda item. Members, do you want to continue?
Go for it.
Okay, great, thank you. Agenda item 5, presentation on medication error reporting by the Agency for Healthcare Research and Quality. Members, the Agency for Healthcare Research and Quality is the lead federal agency charged with improving the safety and quality of healthcare nationally. The agency manages the network of patient safety databases, NPSD, that contains information voluntarily submitted by patient safety organizations. I'd like to welcome our presenter, Andrea Tomaskenska. I hope I said that correctly. Sorry, Andrea. Director of Patient Safety Organization Division at the U.S. Department of Health and Human Services, to provide a presentation to us on the development of the NPSD. Welcome.
Thank you so much. Thank you for having me here today to talk a little bit more about our work. My name is Andrea Timoshenko. I'm Director for the Patient Safety Organization Division within our Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality within the U.S. Department of Health and Human Services. So those are all our PSO, CQIPS, ARC, HHS acronyms right on the first slide to get you ready for our federal government presentation. And thank you so much. It's been a pleasure to be here for this meeting so far and hear from ISMP Canada. I know I learned a lot, and frankly, what some of the work they're able to do around medication error is inspiring to me, and I can't wait to take some of the lessons I've learned today back and to think about that for our work here in the U.S. So next slide, please. So to tell you, kind of set the stage for what we do in our program, the underlying authority we have on a federal level is the Patient Safety and Quality Improvement Act of 2005. And then HHS implemented a implementing regulation back in, published in 2008, became effective in 2009 in order for ARC and primarily one of our other colleagues, centers, agencies within HHS to implement this act. Next slide, please. So, but where did the idea for the legislation come from in the first place? Like oftentimes when we're talking about anything patient safety, we're going to revisit for just a moment to err is human. Within that report, I often like to point to this figure that talks a little bit about both mandatory reporting and voluntary reporting, and the then IMO's committee's thoughts around the ideas of mandatory and voluntary event reporting systems. So their proposals and recommendations centered around this idea that the smaller top of the triangle should be available for mandatory reporting of serious adverse events, and the thought that this was really essential for public accountability. And they also envisioned the larger bottom piece of the triangle for voluntary systems, thinking about near misses and lesser injuries, for the learning to happen there. So for more information to be shared, for more analysis, and for that information to have protection around it so that this kind of safety and learning activities would occur. Next slide, please. For some further details here, the IOM committee encouraged Congress to pass legislation to extend peer review protections for data that's collected for such purposes, recognizing that the where in which states that some peer review laws existed, they were inconsistent, and that they weren't as as impactful as they thought was necessary. And the idea that we'd have this, back to some of the comments we were just talking about, a more conducive legal environment in the United States so that healthcare professionals organizations could do the kind of work that was needed to done to identify and analyze and then in turn prevent errors in the future without increasing the threat of litigation and without compromising the existing rights that patients had. Next slide, please. So Congress kind of took some of this inspiration and took a couple years and considered some different bills and ended up with the Patient Safety Act of 2005. And here's sort of a graphic that we like to use to sort of explain the fundamentals of the system that the Act set up. So of course, the middle, we have safe, high quality patient care is the focus. And then the main actors sort of in that learning system. At the top, we have the providers. So the Act sets up this ability for the providers to work with these entities now called patient safety organizations or PSOs, conducting patient safety activities, which are 8 defined activities within the Act and our implementing regulation, to essentially exchange information for the providers to be submitting data to the PSOs, for the PSOs to be able to aggregate and further analyze that data and send back those best practices and learnings and recommendations to the providers. For the providers to participate with a PSO or multiple PSOs if they want is completely voluntary. And then again, you'll see like the voluntary part of this comes up over and over again. I'm going to say that word probably many times during this presentation. But another piece of that is the PSOs have the option, it's again voluntary, whether they want to submit a non-identifiable version of the information that they've received from the providers to our NPSD or network of patient safety databases. And here we have this data on, again, not identifiable, and I'll explain what that means in a minute, information aggregated that we're able to kind of have a snapshot of what things look like across the United States, with the idea that that information can then be used within the patient safety research in order to hopefully improve the evidence base, the evidence then being used by providers to improve the quality and safety of care. So next slide, please. So where does the ARC PSO program fall into this greater learning system? We're the primary implementers within HHS for the Patient Safety and Quality Improvement Act. Our colleagues over in our HHS Office for Civil Rights do have a role along the implementing and enforcing the disclosure permissions and the if there are any breaches of the confidentiality provisions. But we do most of the other implementation for this act within HHS. So we're responsible for things like and listing and certifying the entities that want to become PSOs or patient safety organizations. Once listed, a patient safety organization, that term of listing is for 3 years. So there's a few requirements that the patient safety organizations need to meet during that term of listing. We make sure that that occurs. We do sometimes conduct compliance assessments as well. And then if we reach when we reach that 3-year end of listing, if the entity wants to continue on as a PSO, there's a relatively painless process to go through to maintain that listing or be relisted for another 3-year period. So we're responsible for ensuring that occurs as well. Congress also gave us the ability, recognizing that this entire learning system, the idea is to aggregate information from all kinds of different providers and different sources to come up with a common way to basic taxonomy to compare these events, so that if we're getting, for example, information on medication errors, every provider at every pharmacy isn't, submitting the data in a different way, that makes it really difficult for us to aggregate and analyze that information. So we also develop what we call common formats to have these basically common language and common taxonomy to identify and submit the data. And then we maintain that network of patient safety databases, as I mentioned, and I'll talk some more about that. Again, our national source of this data that flows from the providers to the patient safety organizations up to us on a voluntary basis. And we also spend, a fair amount of time doing technical assistance. We interact with a lot of entities that are interested in becoming PSOs, with working with PSOs, or others like everyone here today to learn more about, PSOs and the program. Next slide, please. So what really distinguishes this program from other patient safety and quality efforts are those legal protections. The Patient Safety Act was one of the first national in the U.S. Ways to provide these broad federal confidentiality and privilege protections. So the protections are nationwide and uniform. They are not limited to just the peer review process, which was a challenge for some of the statewide level efforts before. And one of the ideas is that this really allows for shared learning. So in some states where similar protections existed, it's not uncommon that there may be facility specific. So say if you have, multiple pharmacies within a system, they often weren't able to share information, from one facility to the other, given the limitations of the state law. And particularly, sometimes that happened within and also particularly across state lines. So if you're part of a healthcare system or some kind of entity where you have, different facilities in different states, that information could be subject to different state protections if the state protections even exist in the different states. And this is backed by penalties. As I mentioned, this is where our Office for Civil Rights comes in. They can enforce if there are violations of the confidentiality provisions. Next slide, please. So to explain what is a little not protected under the Patient Safety Act. There's basically original records of the patients and providers. So things like a patient's medical record, billing and discharge information, other original information. And the Patient Safety Act sets up this idea of a patient safety evaluation system, which is that exchange of this information between the provider and PSO. So essentially things outside of that system are excluded from the definition of what's protected. Next slide, please. And here it goes in a little bit more about what is protected there. So the terminology is patient safety work product. There are different ways that that information can meet this definition. The part of the definition that I am focusing on here is what's most often used at the provider level when they're trying to create something as patient safety work product. As you can see, it's fairly broad information and gives a lot of examples of what that kind of information could be. And there are two prongs to it: that information could improve patient safety, healthcare quality, or healthcare outcomes, and that the provider assembles or develops its for reporting to the patient safety organization, and it is reported to the patient safety organization. So that just gives you an example of the type of information that can be protected. Next slide, please. Who works with patient safety organizations? It can be basically any type of provider at the individual or entity level that's licensed or otherwise authorized under state law to provide healthcare services. So most, applicable here today, both pharmacies and pharmacists can work with patient safety organizations, but where PSO services are available across the healthcare spectrum. Next slide, please. Now, having said that, a lot of the information that we know about how well the program's operating comes from the interactions between hospitals and PSOs for a variety of reasons, including the fact that, for example, this really nice report we have from the HHS Office of Inspector General, they focused on the patient safety organizations and their interactions with hospitals. And they found that more than 60% or around 60% of general acute care hospitals that participate in Medicare work with a PSO. And of that 59%, nearly everyone found that interaction between the hospital and PSO valuable. And about 80% found that the feedback and analysis help prevent future patient safety events. Next slide, please. So I'll switch gears a little bit and talk a little bit more about the common formats. As I mentioned before, common formats in general are the set of standard definitions and forms that makes it possible for us to do these apples to apples comparisons of the patient safety events that are happening all over the country. And anyone can use the common formats. They're available, you know, on the website. But in order for those protections to apply that we talked about, the provider needs to be working with a PSO. It's not enough just to be using this taxonomy to ensure that you have the protections. Next slide, please. We do have a community pharmacy common format available in the common format for event reporting category. You can see here we have these two types of common formats. We have done the most work on common formats for event reporting. We've done not as extensive work on the common formats for surveillance side. Surveillance in this context means being able to do a retrospective chart review and to identify whether specific adverse events occurred or not. There we focused on the hospital setting, but we've been more active in different settings across on the event reporting side, including community pharmacy. Next slide, please. So I'll give you just a little snapshot of what the community pharmacy common format looks like. You know, it's again, here's a screenshot of the top part of the event description for the definition of the event is where all of our common formats start off with. But here gives you an idea of sort of what this is and what the purpose is. So, you know, this is, you know, set up so that a community pharmacy could have like a standardized way that they were collecting this kind of information about different kind of patient safety events that could occur in that setting. In developing this is actually something where the community pharmacy community came to ARC and was interested in developing a common format for their settings, you know, finding that I think at the time, community pharmacy for hospitals may have been the only one that was fully developed, and they liked the idea, but it, you know, wasn't perfect fit for what was going on in the community pharmacies. So with that industry help, we were able to develop this version. Next slide, please. And so again, what do we do with this kind of data that's collected in these common formats? There's these two main data systems. Most really going to focus in on the Network of Patient Safety Databases, or NPSD. Again, this is where that data comes in via the providers to the patient safety organizations to us. As of September, we have more than 2.6 million reports submitted. This is across different types of patient safety events. And this information is currently in the common formats for event reporting hospitals. So as you'll see in a couple of slides later, we do have information available about medication events, but this is information that's primarily in events that are primarily occurring in the hospital setting as opposed to community pharmacies. I did just want to quickly mention that we also do have a quality and safety review system. This stems from the foundation of our common formats for surveillance, and this is a system that we use and a partnership that we have with CMS in order to look whether in certain identified hospital record, whether particular adverse events occurred, and we're able to calculate rates and estimate rates on a national level for different kinds of adverse events. Next slide, please. So here's a graphical representation of that data flow. So we have the providers who submit that patient safety work product, that protected information, to those patient safety organizations. And then here what you see in the middle is this PSO Privacy Protection Center, essentially to make sure that the information that we receive does meet that non-identifiable standard. We have set up this entity in order to help make sure the information is in the proper format and doesn't have any identifying information. The non-identification standard means that you will not be able to identify the patient, the reporter, or the provider who was involved in the services. So it's and that's one of the reasons I emphasize when I talk about it, also using the correct terminology under the Act and regulation, which is non-identification, because occasionally we'll get some confusion with HIPAA and the de-identification there. That's all the standards are incorporated into the non-identification, but it's like HIPAA plus. There's more protections for this data to meet the non-identification standards than just what you find in HIPAA. So again, we have this PSO Privacy Protection Center to make sure that data before it's available to the public has been aggregated and has been de-identified. And then we have our network of patient safety databases, and we have various data reporting tools, which I'll talk about some more, but here are a couple of examples shown. Next slide, please. So as I was saying, here's one of to talk a little bit more about the network of patient safety databases. Again, it's fully available to the public. It's only non-identifiable data. That data is aggregated. It's summary level. There's no information that's at the PSO level, much less the record level data. And we have various data reporting tools. We have dashboards, interactive dashboards that you can go in. These are done by module. And I'll show you an example in a second of some of our medication dashboards. We have chart books as well, which is, actual reports of the data. And that tends to take a pretty broad look at the data we have available. And then we also dig into the data a little, certain topics in data spotlight reports as well. So here's an example of one of our first data spotlights where we focused in on COVID-19. At the time, as you can imagine, COVID was not something that was pre-built into the common formats taxonomy before COVID existed. So we were primarily doing qualitative analysis and seeing what kind of information was available via the free text of that structured data that we had available in the NPSD. Next slide, please. So here are a couple examples, and thinking about doing a presentation and what I could fit on a slide. These are not the most exciting examples from the dashboards that are the medication supplement, but they're some of the easier ones to show you just to get you a feel for the kind of information that's available there. So I do really encourage, if you're interested, to take a look, the links, at the bottom of the slide, so that you can see what we've done with the dashboards. This should say 23 medication supplement. Actually, in the past year, we took a really hard look at the medications dashboards that had been previously available and did sort of a redesign to make them more useful. So if you do take a look at these and you have any comments about what the information looks like, what would be useful, presentation wise, or if there's other data elements you would like to see available or different combinations of data elements, now's a fantastic time to give us that kind of feedback, because we will be in the process of sort of finalizing a new medication combined dashboard. Right now, you'll see the sort of standalone medications dashboard and this supplement, and we'll combine them back together into like a final product in the next year. So it's a great time to provide us feedback of what you think works about the new supplement and what doesn't. But to show you an example, so for example, we in the newer supplement, a lot of the data is dissected by the report type. So we do have, for some of our information, incidents, near misses, as well as unsafe conditions. So you have those three different levels. And then across, those kinds of report types, we have the stage of the event originated. So here you can see for the events that reported, the stage the event they originated by that report type, and some differences that you can see, combining those two things. It's also a decent representation of when you see how big those unknown bars are. There are many data elements for which the answer that is received is unknown. And we would love to have data that has a little bit more of some of those substantive answer values as well. But this is a good reflection of the kind of data that we do get in. So next slide, please. And so here's another example. So this has already been filtered into the events where the incorrect action was was identified as one of the pieces of the issue with this event, and then further dissected by the stage the event originated. So within incorrect action events, then you look at the staging and you can see prescribing. And then within incorrect action, allergen to the patient is the particular issue identified here. You can see prescribing is the stage where the vast majority of these events were found to occur. So again, this is one of like the really simple graphics that's available, but it's looks, moderately okay on a slide versus some of the ones that are much more complicated. And I encourage you to click around and see some of the data. We do have a little bit of data by a few patient demographics available. That's something newer we're trying to do where that data is available. We don't always have great data in order to be able to slice and dice the data that way, but that's something we're trying hard to do where we can, for example. Next slide, please. Okay, and I think, I guess that's pretty much the overview I wanted to give, and I'm happy to take questions.
It'd be helpful if I would unmute. I'm sorry. Thank you very much for your time and your presentation. Members, do you have any questions for Ms. Tymoshenko? I can't see your hand, so I just speak up.
I would just like to say again, thank you, Andrea, for coming to present. Really appreciate your time.
Yes. Thank you. And just as we move on to public comment, I want to remind everyone, as a public agency of the board, is required to accept public comment on each agenda item, including presentations. Public comment is not intended as a question and answer session, but rather provides members of the public an opportunity to comment on the information provided. Ms. Tymoshenko, you're welcome to answer the questions if you choose, but are under no obligation to do so. Are there any comments in Sacramento?
No one is approaching the public comment table.
Thank you. Moderator, we're ready for public comment for individuals participating via WebEx.
We are taking public comment via WebEx. If you'd like to make a comment, please raise that hand by tapping the hand button at the bottom of your screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take a few seconds now to see if we have a request for public comment. As a reminder, you'll be given 3 minutes to speak with a 10-second warning. And it appears we have no request for public comment. Do you wish to continue with the agenda?
Yes, thank you. Again, Ms. Tymoshenko, thank you for your time and your informative presentation. We truly appreciate all the information you've provided. The work that the AHRQ provides a good foundation for our efforts as we work forward in implementing our provision in AB 1286. Thank you. Okay, before we move on to the next agenda item, I think it's appropriate that we take our break. It's now 10:43 and we're required to take a 15-minute break. So we'll come back at 11. Thank you. Well, we'll return back after the break and see, we'll do a roll call to confirm attendance. Renee Barker. Might be on her way back. Indira Cameron Banks.
Both member present.
Thank you. Sung Oh.
I'm here. Chair Serpa.
Great. Nicole Tebow.
Present.
Great. And Renee Barker. She can announce herself when she comes back. She probably was just momentarily delayed. We'll move on. Agenda item 6, presentation of the state contracting process by the California Department of Consumer Affairs. The board has received requests from a number of entities interested in serving as the entity to receive medication error reports under new section 4113.1 of the Business and Professions Code. So continuing with our presentations, we requested that the Department of Consumer Affairs provide an overview of the request for proposal process so that such entities who would like to engage in the process, if they choose to do so. I believe this presentation will also help to inform the committee about the necessary information that will be required as the board as a part of this process. I'd like to welcome Miriam Lopez. She's Staff Service Manager 2 from the Department of Consumer Affairs Business Office. Ms. Lopez?
Hi, good morning, everyone. I am Miriam Lopez, and I oversee the contracts and procurement section here at the Department of Consumer Affairs. So in order for the board to contract with an entity to collect and report medication errors, DCA will need to solicit for these services. And as Maria stated, it is going to be the request for proposal, the RFP process. Next slide, please. So request for proposal is a solicitation method that we will be using to secure complex services calling for any technical and professional skills and expertise. So in an RFP, we outline the requirements such as any administrative technical specifications, our evaluation methodology, bid preparation instructions, and any contract language. Proposers are responsible to respond to the requirements and show how they intend to perform the work. So the estimated turnaround time for an RFP can vary depending on the complexity, but it can be anywhere between 3 to 9 months in order to go from the solicitation to the advertisement and then the contract. Next slide, please. So here is a high-level overview of all of the steps that the RFP process entails. On the left-hand side, we have all of our major stakeholders, and across the top, we show the phases that the RFP process covers. So I will go into each phase and describe what our roles, responsibilities are for DCA, for the board, and then for proposed vendors. Next slide, please. So phase 1 is the request, right? This is where the boards or programs identify a need, and we research those vendors based on that need. We schedule a meeting with my office to kind of go over what those needs are and, be able to clearly identify which method we'll be using, which we have done so already. So it will be the RFP. This is a kind of internal process here, but I'll go over it briefly. So the board EO will prepare our BSO 47. It's our internal request form to initiate the RFP process. There is a template for the RFP that we will share with the EO. It's templated language, boilerplate that goes over the instructions for the RFP, not just for the vendors, but also for our team when it comes to evaluating any of the panel members that will be evaluating the responses. So all of that information is contained in the RFP document. Some resources to search for vendors and also for vendors to search bid opportunities can be found on the left-hand side there. We do post all of our solicitations to Cal eProcure. So this is when the RFP goes live, vendors can go on to search through active posted solicitations for DCA, and you would find our RFP listed there. Next slide. So internally, we do have at least 3 levels of review. So once we determine what the criteria for our RFP will be, it will get assigned to an analyst. It will be reviewed by a first level manager and then a second level manager, which is myself. Then it will go to our DCA exec office for review along with DCA legal for review. Once we have a DCA finalized version of the RFP, it will go to our program contact for final review. and then program executive and or board for final review. Next slide, please. So the advertisement period is really important. So like I was stating before, we advertise the RFP on Cal eProcure. We require at least 30 calendar days for any RFPs to be posted and live. For more complex solicitations, we do suggest anywhere between 60 to 180 calendar days. And that time allows vendors to fully develop a proposal for us, right? To fully develop a response to our requirements and what it is that we're asking for. So on our end, we conduct research just to see what type of vendors can potentially offer this service. And we either send the RFP to them directly if they have a contact address that's public. We also take any vendors that are interested that are in this meeting today. If you send your email to us, we will be able to send you the RFP directly. On our end, we're also responsible for coordinating any Q&A. So while the advertisement is up and posted on Cal eProcure, vendors do have the opportunity to ask questions, to ask any clarifying questions, something that's not clear in the RFP. We do review and post those publicly. So anytime there are responses or questions, we addend the RFP and post that Q&A to Cal eProcure. So it's visible to everyone. And then on the vendor side, like I stated, during the advertisement period, you have that time to review our RFP thoroughly and to provide a response, right? You're developing that response to our solicitation. Again, it's your responsibility as a vendor to make sure that if you do have any questions regarding the RFP document or any of the requirements, that you submit those in writing to the analyst that will be assigned the RFP, and their information will be contained in that document itself. Next slide, please. So once the RFP is posted and we hit the RFP due date, no proposals will be accepted after that due date. Now, all of this is outlined in the RFP document. So the first level of review, once the solicitation has closed, is our team, internal DCA staff, will go through the proposal to make sure that all of the required documentation was submitted. So these are your standard contracting documents. For example, we have the standard 204, which is our pay data record form. This allows us to enter you into our system as a vendor and would allow for payment after the contract starts. We also have other contractual requirements that need to be met. All of these will be listed in the RFP document. So we're just going off of our checklist. Did vendor A submit attachment 4, 5, 6, so on and so forth. Once we have a pass-fail determination, those vendors who have passed will move on to a second phase of the evaluation. So the evaluation really goes into analyzing the response that was provided by those vendors. The criteria and evaluation questions are included in the RFP document, so everyone has access to what it is that we are evaluating in those responses. The evaluation is made up of no less than 3 panel members. So they will score the RFP based off of the information that is provided, and then they will determine what cutoff score will move vendors to the next phase. So the next phase is optional. This is not required. So it will be up to the board and the EO to decide if they want to conduct either a presentation or an interview phase for the vendors that have successfully passed the first phase, the minimum qualification review, and then the proposal evaluation phase. And then the interview, if we choose to go with an interview, those interview scoring criteria will also be included in the RFP, and that's what the panel will use to score those interviews. And then whoever scores highest. And if there's a cost component to this, that's how the contract will be awarded. Next slide, please. So prior to award, the board does have an opportunity to submit input on the potential vendor. We do take their comments in an advisory manner. We do not allow boards to score or provide input in that regard. So I do want to make that very clear. And that happens right before we officially award the contract to the vendor who has scored the highest. Once that happens and we move forward with a vendor, on our side, our procurement analyst will prepare the actual contract packet. So this is what gets sent to the vendor for signature, what actually becomes our executed document. That will all go through us internally. It will go through internal DCA signatures, and then depending on if there's any cost associated with this or value to it that's over 50K, the agreement will have to go to the Department of General Services for final approval. The Department of General Services is our oversight agency, so they oversee procurements that are over 50K. And then for our program side, you will be sent the executed contract and you will be given the go-ahead to let the winning vendor know that they can begin to provide services. Next slide, please. This, I got a little bit ahead of myself, but contract distribution is this. So this is where we execute the contract and let all parties know that the contract is executed and we can begin engaging with our contractor. Next slide. So in summary, our RFP process does consist of 6 phases. Again, overall processing time beginning to end. So solicitation to execution is about 134 calendar days, assuming we go with the 60-day advertisement period. Should you have any questions regarding the RFP process or the specific RFP that we're working on, please feel free to reach out to myself, either my immediate supervisor, Jared True, or my staff service analyst, Michelle Schultz.
Great. Thank you very much for the presentation.
You're very welcome.
I believe this was very informative. And I note that to everyone that this meeting is being recorded and a link to the video will be made available. This is to ensure that interested parties have access to the information if they were unable to attend today. Members, do you have any questions for Ms. Lopez? Can't see any hands, but I assume none. Just as a reminder for everyone, as a public agency of the board is required to accept public comment on each agenda item, including presentations. Public comment is not intended as a question and answer session, but provides members of the public an opportunity to comment on information provided. Ms. Lopez, you're welcome to answer the question if you choose, but you are under no obligation to do so. Are there any public comments in Sacramento?
No one is approaching the public comment table.
Thank you. Moderator, we're ready for public comment from individuals participating via WebEx.
We are accepting public comment on this presentation. If you'd like to make a comment, please raise that hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. As a reminder, you'll be given 3 minutes to speak with a 10-second warning. And it does not appear as though we have any request for public comment. Do you wish to continue with the agenda?
Yes, thank you. And again, Ms. Lopez, thank you for your presentation. This provides a great foundation for our next agenda item. Appreciate your time.
Thank you.
Have a great day. Agenda item 7, discussion and consideration of scope of work and contract requirements for the inclusion in the invitation for bid for interested parties seeking to serve as an approved entity under Business and Professions Code 4113.1. The previous presentation provides an excellent foundation and knowledge as we begin our discussion on our contract requirements. I'm hopeful that as we move forward through the questions, our responses will help to form the scope of work. Let's see, I think we're going to have a series of slides that'll help us with this discussion. The first question for our consideration is staff's request for the committee to provide feedback on required elements of medication error reports. I appreciate the staff's recommendation and note they're in large part similar to the elements included in the common format that was discussed by AHRQ NPSD database. I'm comfortable with these elements, and if you can read them, they're very tiny here on the screen. Give you a few minutes to read them. I believe they provide the framework that will allow the board to gain insight into the frequency and types of medication errors and contributing factors. Members, do you have any questions or comments on these suggested elements?
Yes, this is Nicole. I had a question on or comment on two of them. One, I wanted to know what F meant by type of patient. It says there's a drop-down menu, but I'm not understanding what would be in that drop-down. And then I wanted to comment on H, which is sex. Are we talking about sex assigned at birth, or are we talking about gender identity? I think that that's either needs to be broken out into two, or we need to specify what we're talking about, or potentially remove it altogether, as I'm not totally sure if it's relevant, but those are my thoughts.
Those are really good questions. I'll have someone else speak to the type of patient. I think it may be the drop-down menu that AHRQ referred to, but in the sex, maybe it could be termed differently. But you notice there, Nicole, I noticed that that was not a drop-down menu, so it was not going to be limited. But in some situations, particularly medications that are given to pregnant women or other types of events, that may be a useful data point. But I'd be interested to know the best method to collect that information, and maybe someone from the staff could also speak to that. Can someone speak to the type of patient, what the drop-down choices would be?
Hi, this is Anne. I don't know if that was to me. I'm happy to reach back out to AHRQ. I believe that that was one from them. If we don't believe, I think that it's intended to give some demographic information to help provide a little more context to the medication error in terms of data analysis. Age gives you one type of characteristic, but there may be other types of means by which you would want to to look at the data. So I'm happy to get those different values for the committee moving forward.
Thank you. Yeah, and going back to the sex, I just get concerned, like if there was an error. You make a great point, Maria, about a woman of childbearing potential or a person of childbearing potential, but that would also be important to know. If we have a trans man who is pregnant, that would be important to know. It would also be important to know if there was, say, a drug issue on testosterone. Those doses are going to look vastly different for someone who is receiving it for transgender medicine versus someone who is a cisgender male receiving testosterone. So those are some of the things we're going to need to know to help us assess the error.
Very good points. I'm thinking that maybe why it is a not discriminant data point. It is a it looks like it's probably a free form entry, but those are good discussions. I think we'll probably discuss that as we move forward during this process. Any other comments from members? Or sorry, did I cut somebody off?
I was just saying thank you.
Hi, Maria, this is Renee. And just for the record, I did join just a tad late. Sorry about that. And when you were introducing the previous agenda, I was on, just to get that noted. Thank you, Nicole, for that, because I was also going to mention that about H for sex, because that's doesn't seem to be the term that's requested. I also, so just this is kind of based on my own experience with the error reporting system used at the institution where I work. And there are more identifiers for the patient, which I think would be helpful. So so in addition to, gender, so there's could also be race or culture. These are some of the questions that we are required to complete in our error reporting. So a question might be, and I know this is very discrete, but this is more in a sentence. Do you think race, culture, or gender played a role in this event? So however we could capture that, so by including at least race. And then maybe some more specific for the type of patient. So we have age, I mentioned race, they have ethnicity, spoken language, ethnic background, written language. So because I'm just trying to capture who's experiencing these errors and if there's any contribution there. And I can't, did I mention the other was a question was, were there any language barriers that contributed to this event? So that can also apply to staff as well as a patient. So because I think many pharmacies have people with many different primary languages. And my only other comment was about M for was technology involved? And then yes or no, so that's great. But if yes, it says brief description. I'm just wondering if there could be any other, say, drop downs for that, because I think in the use of technology, I think there's many pharmacies have multiple different types of technology, and I think it could be the source of an error. And so it wouldn't allow for elaboration. There's probably a free form. There's probably free form, but it just depends on if it says brief, like how brief that would be. Also, it might be helpful if people were prompted through some questions about if it was a like equipment type of error. So technology or equipment. So because it could be like a computer system versus a like a scale or a counting device that somebody might want to elaborate on. So that's kind of my only feedback on those. Thanks.
Thank you.
I guess great minds think alike. I was gonna say something about the H as well, the H as well as the technology. So hoping technology, we can add description, but also add some more drop-down options if there was, so that it could streamline and be able to, because there are technologies that are very commonly used that I think we could add into it, such as, automatic dispensing machine, counting, or photographic technology. And technology is a little big, so I think by having some options there that could help stakeholders and regulated public answer this appropriately.
One of my concerns is the elements that we have here will probably be in place many, many years. When you look at the contracting process and also for our database, we don't want to necessarily have, unable to compare multi-year comparisons. So we say we collected these elements in this year and this elements in the other year, so therefore we can't compare the years. So, and technology is often changing. So as long as there was like an other that we could put in that would not be limited, but it could be that in 5 years, there are no whatever kind of technology that we use today. There'll be something else that'll be there. But I'm wondering what you all about the term gender instead of sex, or is that more controversial? I notice that's what AHRQ uses, but again, that's the federal government, and they probably developed that a decade ago or longer. So terms have different meanings now, so I'm not quite sure what the right term is for that. I did like some question about language barriers, and then describe maybe instead of having language spoken or that kind of stuff. I think that's a very interesting concept that we should consider is, was there a language barrier? Part of the challenge for these elements is to have distinct data elements, because those of us that use databases know the power of data, but yet you want to have some evaluation. I think one of the things that came to my attention as we're looking at the volume of errors that are going to be recorded, and the possibility of someone actually reading them and evaluating the free-form part is only going to be on those things that we have a specific question. I don't think that there'll be enough people to read every single data submission. That would be really a lot of the crunching that will happen. But interesting comments. Any other comments from members?
Maria, I just wanted to, about the discussion for M about technology. I mean, I completely agree. I know different technology is it's always, appearing around the corner. But I think there's maybe some distinct categories that could possibly be listed. So for instance, like an IV workflow manager, there are many, but they're all kind of termed under that. And possibly like a, ADDS, automate, those types of things. And then there'll be just different manufacturers. So that could be the general category.
I can work with staff to bring something to the board meeting that is a little bit more descriptive, and we can continue our discussion there. Good feedback. Good feedback. Any other comments from members?
Yes, Maria, this is Nicole. I just wanted to second what Renee had said earlier. I think it would be great if we could collect data on like race and ethnicity to look for if there are discrepancies. We know that there's a lot of, implicit bias that exists, and we have to, I think it would be in our best interest to look if that's playing out in medication errors, because that would definitely be something that if we don't have that data, we might be missing an important area to follow up on.
Okay, thank you. Any other comments from members? Yeah, I think we're ready for public comment. Any public comment in Sacramento?
No one's approaching the table.
Okay. Moderator, we're ready for public comment for those participating via WebEx.
All right, we are accepting public comment via WebEx. If you'd like to make a comment, raise that hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Kathy Gomeshi. Hold on just a moment. We're going to send you a request to unmute your microphone. You'll be given 3 minutes to speak with a 10-second warning.
So sorry, my hand was raised in error.
All right. Do you want to say what you wrote in the Q&A box?
Oh, sure. Thank you. I am a medication safety officer, and so I work very closely with incident reporting systems. And just a comment on some of the questions that arose during the discussion. So some incident reporting systems might be set up with gender assigned at birth, sex assigned at birth, gender identity, things like that. There might be diversity, equity, and inclusion fields such as like, what is your primary language? What is your race or ethnicity, your religion, etc. And then in terms of some of the commentary that was discussed regarding technology, I'll just say I've been reviewing medication errors for about 10 years, and I've seen thousands upon thousands, and technology can span all of the scenarios you've described in terms of automated dispensing cabinets, IV workflow software, but it can also be how a system might be set up, human factors engineering. So if a system is set up in a
manner that the technology makes it easier to do the right thing and harder to do the wrong thing. That's ideal, but sometimes systems are inadvertently set up in a manner that can be confusing and can contribute to medication errors, or a computer program of some sort may have some errors in their setup as well, and that can be a contributing factor to medication errors. Thank you for allowing me the opportunity to clarify some of those comments. Thank you.
Thank you.
All right. Next, we're going to hear from Victoria, followed by Richard. Hold on, Victoria Kroger. We're going to send you a request to unmute your microphone.
Can you hear me?
Yes, go ahead, please.
Excellent, thank you. Hi, I'm Victoria Kroger. I'm a manager for the Walgreens Pharmacy Affairs team, and just wanted to first thank the board for the discussion on this topic and thank them for the opportunity to comment on these proposed and suggested elements for patient safety. Walgreens, as you know, and many other organizations already participate in patient safety organizations. By now, I'm sure you all understand that these organizations are analyzing data and providing feedback aimed at promoting learning and minimizing patient risk. As you heard, the Agency for Healthcare Research and Quality enlists lists entities as PSOs when they meet the requirements of the Patient Safety Act. These well-known and established entities already have codified standards for reporting quality events, and the minimum elements suggested to be included in error reporting here with the board go beyond what is utilized by the AHRQ. Walgreens suggests that the committee does not recommend the suggested minimum elements to be included in error reporting. We request that the PSOs, the AHRQ, and the outlets are allowed to continue to determine elements that should be included based on the tasks completed, workflow setup, specifically because each entity has different needs, processes related to quality improvement. Each pharmacy organization that utilizes a PSO also utilizes varied structured data and processes for reporting their errors, but not necessarily every element as suggested to the committee, because it is not always required to provide the best data for analysis. The elements needed for quality and safety reporting should be dynamic and based on what is best for each pharmacy organization to make sufficient and effective recommendations to improve safety. A one-size-fits-all approach, especially one as suggested with the consistent use of specific drop-down menus, will not provide the best results for analysis to improve patient safety for patients in California. As the experts in safety, the PSOs should continue to use the well-regarded and nationally recognized standards for error reporting, and any redundant or unnecessary elements of error reporting required by the California board should be avoided. I thank you very much for the opportunity to comment and look forward to further discussion by the board. Thank you.
Thank you.
All right, next we're going to hear from Richard. Hang on, Richard Deng. We're going to send you a request to unmute your microphone.
California Pharmacists Association. Great conversation on the different elements that are there. I do want to echo the previous speaker to caution the board from creating any extra elements beyond those that are currently used. I think the reality is each company and each pharmacy has their own reporting structure currently, and the most likely way, as we've heard from previous processes, is the data is going to be reported to an intermediary that then needs to be translated and put into a standardized format. So the more we deviate from those minimal accepted elements and data points, the more complicated that data transfer is going to be at the intermediary. I think we have real life example of this happening with vaccine data, when it was mandated that all vaccine data be reported up to CARE. And during the COVID pandemic, race and ethnicity was an added element, and that caused a lot of issues amongst vaccine providers, because especially at the pharmacy level, that's not something that's usually collected at the point of intake, and that's not information that was collected and that then could be reported. So then CARE had this really big issue where they couldn't process the data because it was missing those newly required elements. That's not something that's part of the traditional workflow for pharmacy or other vaccine providers. So while well-intended, it caused a lot of issues on the data collection and analysis piece. So I just, again, we use that as an example to caution the board on adding more elements than what might be needed or necessary to get to the root cause of the medication error. Thank you.
Thank you.
All right. Next, we're going to hear from John Gray. Hold on just a moment. We're going to send you a request to unmute your microphone. All right, John, it looks like your audio is hooked up by phone. You may need to dial star. Oh, you've unmuted. Go ahead, please.
Yep. Yeah. Thanks so much. The unmute me button was just a little tardy in getting to me. I guess the tubes and vacuums weren't working as fast as they usually do. Yeah. So appreciate. This is John Gray, registered pharmacist with Kaiser Permanente. Appreciate the opportunity to provide comments on this important topic. I guess I just have what might be a naive question for the board, and that is what the board views as the specific purpose for requiring the submission of a pharmacy identifier, pharmacy identification code. We heard today from ISMP Canada that they do not collect data that would allow for identification of the pharmacy where an error, a reported error occurred. Similarly, the AHRQ community pharmacy common format does not include data that could identify the pharmacy in which an error occurred. Certainly, we appreciate that the law specifies that these reports are confidential and not subject to discovery and must be de-identified if reported in summary format. I just want to flag that those protections are important, but are unlikely to stop frankly malicious actors whose sole purpose is to steal data. And so I am concerned that any identifier, even if it's a code or a key, could be inappropriately accessed and ultimately used to track back to the particular pharmacy. So again, would ask the board to really think hard about the necessity of reporting pharmacy identity even by code into the system. Thanks for the opportunity to provide comment.
Thank you.
And we're going to take one last look around, but that should be all of our requests. Nope, we have more requests. Next, coming from Meg Hogan. Hold on just a moment. We're going to send you a request to unmute your microphone.
Medical Center Pharmacy in Long Beach, California. We are a compounding pharmacy that makes intrathecal drugs that we ship directly to prescribers. And while I appreciate the board's interest in some of the data you want to collect, it would be very difficult for us to collect data on issues, things like race and sex. That is not something that comes in from our prescribers. We take prescriptions. We do have some data on our patients, but it is not something that we normally collect, and I don't think it's something that we would want to normally collect, to echo John Gray, because it's one piece that would go into our PHI that would not be necessary. Thank you for your time.
Thank you.
And next we have a request from Paige Talley. Hold on just a moment, Paige. We're going to send you a request to unmute your microphone.
Thank you, moderator. This is Paige Talley representing the California Council for the Advancement of Pharmacy. And I'll be brief. I just want to say that I agree with all previous speakers that especially the first two that talked about the sex and race is unimportant, and I agree with that. And what John Gray said is also very critical and should not be included. And the last speaker too. Thank you. Thank you.
All right, we're going to take another look around, and that should be it for the moment. Nope, hold on. Next we have Stephen Gray, Bear with us just a moment. We're going to send you a request to unmute your microphone. All right, Stephen Gray, we've sent you one request. We're going to send you another.
Thank you very much. First of all, let me state that though I am retired, I have over 30 years experience collecting dispensing error reporting data for an organization that serves 3 to 9 million Californians with over 400 pharmacies and 30 to 40 hospitals. What I've learned through that is that there are certain items that are not listed here that are very important. Also, to get back, the error reduction task force was primarily about staffing. And so some of the things that are missing would be, for an example, the work hours per day, per week, per pay period of the personnel involved. That is a recognized feature for making errors in many industries, including pharmacy. Labor Code sections 850 to 856 do set limits on the hours of work for pharmacists and pharmacy technicians. So it's already part of California law. So that might need to be added. The type of pharmacy, if you're just thinking whether it's a PHY community pharmacy, that's not good enough. A lot of pharmacies that make IVs, that serve long-term care, that serve oncology operations are listed as PHYs, but that doesn't really, so the drop-down menu there does not mean, should not mean only the prefix for the pharmacy license. The largest number of errors by percentage that we ran into were dispensing to the wrong patient. So you need to identify, the patient, was it the patient that was intended or the patient that received it, or both, and identify, because there could be harm done to the patient that didn't receive the medication as well as to a patient that received a medication for another patient. One of the things that we know prevents errors is consultation. You need to identify whether consultation was performed. We know that prevents errors, and that needs to be identified. And then California law, somewhat unique to many states, identifies errors, problems with impairment of pharmacists and other licensed staff. There needs to be a question about whether there was any impairment involved in the error that was made. And I do agree with what John Gray said. There should, I don't understand the need for a pharmacy identifier, unless you mean that to be the type of pharmacy. But a pharmacy identifier should not be included as he outlined, unless the board has some alternative purpose in mind. So those are my comments. Thank you very much.
Thank you.
Thank you. And we're going to check once again. That appears to be all of our requests for comment at the moment.
Thank you. Yes, we'll continue. Just as a summary.
Yeah.
Just as a summary to this section, I think that we've heard some really good comment from both members and from members of the public. I hear that Dr. O wants to state something else, but I'm thinking that one of the things that we need to keep at the forefront of our mind is the data elements that are similar to AHRQ are probably one group, and then those that we want to consider adding would be another discussion, because that's something that potentially is not being collected by pharmacies, PSOs, or other organizations. And the value of those additions would have to be very very much discussed and evaluated. I would not like to add too many data elements, because then we just will have less reporting. These elements and this information should ideally flow almost in an automated fashion. And so that's how AHRQ works. And so that would be my only comment about adding to the AHRQ elements. We probably need to list which ones are AHRQ and which ones we're adding, so we can discuss them kind of a little bit more individually. Those are kind of my thoughts. I think I heard Dr. O having a comment.
Hi, thank you, Chair Serpa. I just wanted to add to your comment. After hearing some stakeholder comments, I am, definitely understanding the sentiment and the reason for wanting to add some of the elements, but I do think that intent of this legislation and also intent of why we were supporting it is mainly to have some mass gathering of data, and I don't want anything to hinder it. So I am thinking that it's probably best to keep it as simple as possible, mirroring AHRQ, so that things are streamlined as much as possible. I do think that we do have a very powerful regulation already in place in California. As you all know, we have quality assurance reporting, which is going through the regulatory process. It may be best that we, take these comments and possibly also think about amending those regulations instead. There are great comments that are made about some of the additional elements that may be beneficial. But I do see a challenge of having a mass gathering with our own additional, information. So I do agree that it may be best to try to keep it as simple as possible. And I'm saying this with total understanding that added such information like sex would be, the gender or whatnot would be very valuable, but may be hard to gather in a mass information gathering setting. So probably best to keep it simple after hearing some stakeholders.
Members, any other comments?
Yeah, this is Nicole. I definitely appreciate people's point about it being hard to get this. Perhaps some of these data element points could be that you put it in and the option is if known. So if you don't have the data, you don't have to fill in that option, but if you do have it, you can put it there so we can begin to gather some of this data.
Good comment. Renee and Indira, are we ready to move on?
Yes.
Okay.
Yes, thank you.
The next for our consideration is the question of whether the selected entity would be required to provide a process to collect data from all required reporters and report, summarize, and evaluate the data and provide recommendations. I believe the answer to this question is yes. It's important to have a single entity be responsible for the end-to-end process for medication error collection through evaluation and development of recommendations that can be used to inform pharmacists and pharmacies in practice changes to reduce errors. This is the only way that we can prioritize areas of focus and determine next steps if all the reported errors and data are evaluated in a single common database. This avoids confusion. Just to avoid confusion, because this is an area that has caused a lot of questions, there's another question further down that speaks to the manner in which medications errors are collected. So that's a different question than the question that we have here, which is the selected entity would be required to process and collect all required data from all reporters in the state. Members, do you have any questions or comments on this?
I agree with you, Chair Serpa. I'm taking silence as probably agreement for some questions.
Good. And we'll go to public comment. Sacramento, any comments?
No one is approaching the comment table.
And moderator, we're ready for comments from the public via WebEx.
All right, we're once again taking public comment via WebEx. If you'd like to make a comment, raise that hand by tapping the hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Victoria Kroger. Hold on just a moment. You'll be given 3 minutes to speak with a 10-second warning.
Hello again, Victoria Kroger, manager with the Pharmacy Affairs team for Walgreens. We wanted to recommend that the board, as they evaluate this process, ensures that none of the processes from the entity violate any components of the Patient Safety and Quality Improvement Act. So as you're considering your vendors and the contracts, I think it's very important to make sure that there aren't components that would violate the PSQIA. Additionally, I want to thank the board for their discussion, providing reports. When a entity submits their data, the reporting should also be available to them so that analysis and improvements can be made. If these reports are not shared, there will be a loss in effectiveness of the quality reporting and an entity's ability to make process improvements to prevent errors. So I appreciate the board's kind of strong position on making sure that when the analysis and reports are completed, that it will be shared back with the entities at large. Thank you very much for the opportunity to comment.
Thank you.
All right. And we had another hand up, but it's disappeared. We're going to give that hand just a few seconds to reappear, and then we'll move on. All right, I also see a request in the Q&A box. Hold on, Stephen Gray. We're going to give you an opportunity to speak in just a second.
Thank you again. I agree with the statements made by Chair Serpa that it should be a requirement to get the information back. That's super important for the board to know, what is causing errors, where the priority should rest. Is it something that can be helped by a regulation or not? All of that is very important for the board to know. However, I want to make a comment on the last commenter from Walgreens. We heard from myself and from John Gray that we didn't understand why there needed to be a pharmacy identifier. It seems that there has to now be a pharmacy identifier if the contractor is going to send the information back to the various pharmacy organizations that are supplying the report. So I just there seems to be a conflict there, and maybe that's why that was on the list to begin with. Thank you very much.
All right, thank you. And that hand I was looking for never reappeared. Oh, hold on. Did I just see? I have a new hand. Not the same one as last time. Peggy Binzer, hold on just a moment. We're going to send you a request to unmute your microphone.
All right. For folks to provide comments on your scope of work and contract requirement discussion. I think it's so important. The Alliance for Quality Improvement and Patient Safety, we are the professional association for PSOs and their member providers. And I think that what the previous comment was about giving information back was if there are recommendations, they would go to everyone because that's really the learning system. PSOs are required to provide individual feedback to each individual provider. And I think it would be difficult for the board to provide individual feedback, given that every pharmacy has a different process and different proprietary processes. But there is a lot of great information that you could collect and provide feedback to as more of a general recommendations rather than process changes and other very individual recommendations. So therefore, I don't think that the pharmacy identifier would be necessary, and the cost provided for the entity to provide individual feedback would really be cost prohibitive and duplicative of the Patient Safety Act. So thank you. Thank you for the opportunity to provide comments.
Thank you.
All right, looking around once again, this might be our final call. And those are all of our requests for public comment at the moment.
Thank you. Before we move on, I wanted to remind members that if you're having technology issues that we can't see or hear you for a particular time, please let us know so that we can document that for the minutes. I see that some of the cameras are going in and out, so perhaps there's a bandwidth issue. Just let us know so that that can be documented. Thank you. Next for our consideration is the question of frequency within which data is provided to the board, for example, quarterly, semi-annually, annually, or upon request, etc. So that's the next slide.
I would.
So let me finish. I'm sorry. Just wanted to make sure the next slide. So my suggestion is that at least for the first year, that there may be some value in requesting quarterly reporting. We can start to receive the data and begin to learn from it. I think the frequency could potentially change to semi-annually after we feel comfortable, but I also believe there's an ability that we need to have to ask for additional information on an ad hoc basis as we need it. Members, what do you have, any comments or questions?
I agree completely. I was going to say at a minimum quarterly. So agree with you, Chair.
Any other member comments? Any comments in Sacramento?
No one's approaching the table.
Moderator, we're ready for comments via WebEx.
We are once again accepting public comment via WebEx. If you'd like to make a comment, raise that hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you. Let's move on to the next question that we have to consider is how frequently do we believe it is appropriate for the entity to provide summary reports to the boards on findings regarding trends that may be published and disseminated? I believe that summary information should be developed and released at least semi-annually, especially at the beginning as we collect data. Members, do you have any comments or questions about the frequency on summary reports on trends?
This is Nicole. I agree.
Any other comments? Thank you, Nicole. Any comments in Sacramento?
No one's approaching the table.
Any comments from public participating via WebEx?
If you'd like to make a comment on trends, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. We will call on people in the order we have requests. If you're having trouble finding the hand button, please type the word comment into the Q&A box in the lower right-hand corner of the screen. And we have a request for comment from Stephen Gray. Hold on just a moment. We're going to send you a request to unmute your microphone. All right, Stephen, we've sent you a request.
Thank you again. Again, from my experience, I found that we would get reports in occasionally of something so serious that immediate feedback needed to go out to all of the pharmacies, whether it was a drug identification problem or a technology problem or something of that nature. I think there needs to be some provision in the contract where the board is satisfied that if the entity identifies something very serious that could cause patient harm or public harm, that they will be notified immediately. And I don't know how to word that, but if it's not in the scope of work, it won't be developed and committed to by whoever gets the contract. So we did find that there were certain drug combinations that caused severe harm, even death, that we had to send out something like a Class 1 recall notice, if most people understand what that's all about, immediately when something started to appear. On the other hand, ISMP sometimes would identify these and send them out maybe annually or generally, but they didn't necessarily work for an individual organization where there was a particular problem. So I recommend that you include that in the scope of work. Thank you.
Thank you, Dr. Gray. You're seeing our next couple of questions and helping us to segue there. Thank you. How's the last?
Go ahead.
I'm sorry, I didn't ask you. Are there other comments?
No others.
Okay, sorry to step on top of you, David.
It's all good.
Maria, this is Renee.
Yes.
Yeah, so on 5, correct? I'm reading ahead. So this was to disseminate information to exactly who? So gain from the reporting. So, you know, in the Canadian presentation, they, you know, I mean, so it go to all reporting pharmacies. There's also like a public. I mean, I don't think any of these questions address that, which is something I was going to ask. But, you know, like what would the public see if there's something, you know, that element to things.
The who?
Who's the reporting to?
I think in one of the questions it talked about pharmacists and pharmacies, but we certainly could be more specific.
Yeah, I mean, maybe I guess I'm not clear on what is the public's view or benefit from this. Do they see? Are we discussing something like that? The Canadian one had where they could go to a website or they could subscribe to get information, but is that not within the scope here? Are we really keeping it towards reporting to pharmacies for improvements?
So maybe Corinne or Anne could actually speak to the specifics of AB 1286. I think it's a limited scope at this time to patients collecting data for improving patient safety recommendations. But Anne or Corinne?
Hi, this is Anne. And then Corinne, if you have legal things as well, but just wanted to, in general process, Renee, I believe that the intent is for the vendor, or what we're discussing is the vendor providing this information, both making it available, but also to the board. And then because we have the requirement for, you know, maintenance of the emails, then we are well positioned to also assist in the dissemination of the information through both our website as well as our alert system.
Okay, thank you.
Thank you. That's an excellent point. I didn't think about this, how we're talking about the vendor providing information to the board, and then the board could decide what to do with that information. Thank you, Anne. Corinne, did you have anything to add? Otherwise, we'll move on.
Nothing to add on that. Thank you.
Thank you. And thanks, Renee. That's a good point. As with the last questions that we just finished discussing, staff is also looking at the direction on the frequency for development and dissemination of information gained from reporting to improve patient safety, such as recommendations or best practices to be implemented. Excuse me. I believe this question really gets to the core objective of the underlying legislation. In some instances, annually may be sufficient. However, there are going to be certain kinds of errors that warrant a more immediate action, like we heard in the previous discussion. I think we need to establish a minimum frequency and then consider a requirement for release of information, such as safety alerts, when an error or errors reported reveal a significant risk to patients and must be addressed more quickly. Members, what are your thoughts on this?
Hi, Maria. I definitely agree about creating a minimum and then being able to send more. My initial thought when I read this question it would be great if we could get it out like basically as frequently as we do the script, maybe as an addendum or just like a little blurb in there. But I would support like an annual minimum with more frequent for more timely releases.
So I think just to be clear, this is not talking about just the data, but it's talking about recommendations and best practices. So the actual evaluation. So I'm thinking that we probably want the data more frequently, and then the evaluation of the data less frequently, but developing a minimum. Is that your thought?
Yeah, I think that makes sense.
Members, any other comments? Okay, any comments in Sacramento?
No one's approaching the table.
Thank you. And moderator, we're ready for comments from people via WebEx.
We are now accepting comment on 5. If you'd like to make a comment, please raise that hand by tapping the hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Peggy Benzar. Hold on just a moment. We're going to send you a request to unmute your microphone.
Thank you so much. I just wanted to make a mention that the law allows pharmacies to report through, for example, a component PSO or other agent. And in the case of the PSOs work with their pharmacies to implement best practices and to make change. And so I just recommend that we not overlook the PSOs that are making reports to the vendor, that the same information that goes to the board also goes to at least the PSOs and possibly other agents if they're used, so that implementation can be hastened. Review and implementation of the best practice. Thank you.
Thank you.
And that was our only request.
Great, thank you. The next question is, do we believe there are certain types of events that should be identified immediately and potentially released as a safety alert within a specified time frame? As I previously shared, I believe there's a potential for some issues that would occur that would require more immediate release of information. I would suggest that when such an issue is identified, dissemination of information should be possible within a number of days from identification. I believe it's important to provide sufficient time for experts to evaluate and make the recommendation that we do not create new risks or have unintended consequences without having further information before releasing those immediate needs. Members, what are your thoughts?
Hi, Maria, this is Renee. Yeah, I would definitely want to see that there would be the requirement to have some type of immediate release, like you said, like as a safety alert shortly. I mean, I feel like an example might be sometimes when there's a new drug and it looks just like another one. And sometimes that's when, there's an error, kind of lets people, be on alert, something like that. So I do think a very quick turnaround. I'm not sure what seems reasonable, but seems fairly immediate.
Yeah, one of the challenges I had in my thoughts on this was that, rather than put a number as like being a requirement that we'd have like 2 days or 10 days or 7 days, that there really some way of impressing the immediate need, but also without creating unintended consequences. All of us have seen where you change a process and then you don't realize that other things break along the way and maybe cause more harm than the original issue. And so a little bit of time is needed to evaluate it, but still not so much time that errors are still happening out there in the community. So it's kind of a balancing act there. I think that the board needs to have that measurement or that weight of comparison, the time versus the risk. So thank you. Members, any other comments? Any comments in Sacramento?
No one's approaching the table.
Moderator, we're ready for public comment for those participating via WebEx.
All right. Raise those hands if you want to make a comment. Tap that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request, do you wish to continue with the agenda?
Yes, thank you. Members, the next question is, in addition to the predetermined reports, I believe there's value in ensuring the board can request ad hoc reports. Members, what are any comments on this issue? Seeing none, any comments in Sacramento?
No one is approaching the table.
And let's look for comments via WebEx.
We are taking public comment via WebEx for number 7. Please raise a hand if you wish to make a comment. Tap that hand button at the bottom of the screen, or dial-in users dial *3 to raise a hand. We're going to take just a few seconds to see if we have a request for public comment on number 7. Seeing no request, do you wish to continue?
Yes, thank you. As we heard during the DCA presentation, there will be a panel that will be reviewing the request for proposal submissions. And I'm asking if we wish to appoint a member of our committee to be on that panel to be responsible to review proposals and selecting a vendor. Members, I'd be happy to serve as a delegate if you're comfortable with me doing so. That recommendation would not be done solely by the panel, but it would come back to the board for ratification. Members, any comments?
Maria, it's Nicole. I would support you serving as a delegate.
Thank you.
This is Renee. Thank you, Maria. And yes, I would definitely support you being a delegate. Thank you.
Thank you. I'm sure this will be an interesting process. Any comments in Sacramento? I'm hearing none. Any comments for I think we're ready for comments for via WebEx.
All right, if you'd like to make a comment via WebEx, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Peggy Binzer. Hold on just a second. We're going to send you a request to unmute your microphone.
Hi, this is Peggy Benzer from the Alliance for Quality Improvement and Patient Safety. I think it's a great idea to have a member of the board with your expertise to be part of the selection panel. However, I am concerned that we've only had 2 presentations from organizations that could potentially bid on the RFP, and it seems to be an unfair advantage given that there are other organizations that are doing this now that might give feedback in a different way or might have different ideas. And it would appear to me that given the only context is the Canada ISMP as well as the ISMP's previous presentation to the board in another committee, that I fear that that may be used as a standard. And so I'd recommend that if someone from the board is a member of the panel and is making those decisions, that we allow others to make their presentations to the board. I do know that at least 3 or 4 organizations have requested to make presentations and have effectively been put on hold or denied that opportunity. So I really urge you to consider allowing other organizations to make presentations. Otherwise, I think there could be some innate bias in decision making. So thank you so much for the opportunity to make a statement.
Thank you for your comment. You give me the opportunity to help clarify the issue. Our presentations we had today are from organizations to provide background on how they have their processes and systems. They're not contracting of individuals, and they're not individuals that will be responding for the contract for California. There are many companies and groups that will be interested in applying for the contract, and that's why we have the RFP process. During that RFP process, the DCA does allow for interviews or presentations, and the panel will decide which companies or organizations are interviewed, and the board will be able to review that information, but that will happen in the panel. So just to be clear, that our committee here today had 2 presentations from national organizations, from the Canadian National Organization and the United States National Organization that is doing what we plan to do. And so we were looking at them as resources so that we can learn from their experience and hopefully have a really great program up and running pretty quickly. So I hope that's clear. We're not meaning to not allow others to participate. We do have the RFP process. Corinne, did I state that correctly, or is there anything that you wanted to add?
No, I think you stated it perfectly fine.
Okay, thank you. I just want to make sure I didn't overstate or misstate something, but that's something that the board is very cognizant of, is we don't want the perception of specific choices of individuals, especially when we have a contract process that's about to begin. We make no comments on those that are about to request contracts. Any other public comment from people on webinar or WebEx?
Yes, indeed. Next, we're going to hear from Kathy Gomeshi. Hold on just a moment. We're going to send you a request to unmute your microphone.
Hello, Kathy Gomeshi, Medication Safety Officer. I just wanted to comment that the DCA presentation was very insightful in terms of the process for implementing and operationalizing this effort. It may be helpful for community pharmacies and health systems alike to have sort of maybe like a flow chart or timeline of some of the necessary steps for this implementation, so that if there is sort of any proactive feedback, that there's ample opportunity to share that so that this is as successful as it can be. And I did also want to just share the comment again. I've mentioned this in past meetings as well, but there are many entities that are currently reporting to patient safety organizations. So if it is at all possible to consider a preferred patient safety organization for those not already reporting to one, but if you can demonstrate that your structure and processes have, reliable reporting to a patient safety organization, to maybe have that as an exemption so that there is not double reporting or changing of reporting systems. Many of our hospitals in my health system, well, actually, we report all of our Med-Air data to CHPSO, which is I don't want to misspeak the name, but it's the Collaborative Healthcare Patient Safety Organization, part of the Hospital Quality Institute. And so if a new patient safety organization is designated, we would then have to either choose to stop reporting to our existing PSO or do a lot of heavy lifting to report to the new designated PSO. So I just wanted to plant that seed again in case that is a consideration as this gets operationalized. Thank you.
Thank you.
And next we have a request from Tara Modaset. Hold on just a moment. We're going to send you a request to unmute your microphone.
Hi. Yeah, I just wanted to support what Kathy just said, that, for example, we work with independent and regional chain pharmacies, and I don't know, how this is going to flow, but it'd be, my concern would be that we have pharmacies reporting and we're working with them, and then they would have like a double type of reporting that would, cause extra work at a time that, we're trying to keep the workload off, and so that you consider how those that are working with a PSO could then, work under this new construct. Thank you.
Thank you.
And those are all of our requests at the moment.
Great, thank you. We'll move on to the next question. As the contract will be fully funded through licensees reporting to the entity, do we as a committee believe that the cost assessed to each pharmacy reporting should be a factor in determining the entity to receive the award of the bid? I feel strongly that cost needs to be a factor in our decision. Members, what are your thoughts?
Yeah, this is Renee. I mean, I think absolutely, definitely needs to be a factor.
Just affirming my silence as agreement, Chair Serpa. Yeah.
Thank you, President O. Okay, any comments in Sacramento?
No one's approaching the table.
Moderator, we're ready for individuals participating via WebEx.
All right, please raise those hands by tapping that hand button at the bottom of the screen or dialing *3. And it looks like our first request is coming from Stephen Gray. Bear with us just a moment. We're going to send you a request to unmute your microphone.
Thank you very much. I agree that this needs to be probably a business expense of the entities, the various pharmacies or pharmacy organizations. But I do think that there may be some latitude or necessity to apportion the cost somewhat consistent with the magnitude or the size of the organization. So I don't know exactly, Chair Serpa, how you had in mind, but would it be by entity such as the corporation, or would it be by the a fee to each individual licensed pharmacy, et cetera, et cetera? So that was my only concern about this. It could be a considerable cost, or should it be proportional to the number of errors that are reported as an incentive not to make errors? But I give that some thought, as I just would like to see it, apportioned justly. Thank you.
Thank you.
And that was our only request for 9.
Great, thank you. Our last question, I think, gets to the heart of some of the comments that we've heard throughout this morning, and I hope that this is an area that we can help to clarify and discuss. I feel pretty strongly on this. Do we believe that the entity needs to provide a variety of means for pharmacies or their agents to submit data reports, such as through a portal or emailing of a data file, or via third-party entities such as the PSO or other types of organizations? Should we have multiple ways that the information could go into the database? Members, any comments or questions? I think I've stated that this is important because every pharmacy may need to determine how they can best submit data. They may have an IT system that they can do it on their own, or they may have some sort of automated reporting already, or they may have limited systems and not have access to certain types of automation and need to go through a portal to submit the information. Members?
I just want to agree completely how important this is, and that this would be crucial for successful implementation of this very exciting bill that we have signed. So I think it is important that a pharmacy owner with one pharmacy to a chain pharmacy to a pharmacy with all different settings, and as well as pharmacies that handles 100 prescriptions a day to 1 million prescriptions a day that are mailing to, for everybody to be able to report this. And that's going to be such a key to the successful implementation. So I think this is crucial. We make it as flexible as possible, as much as we can.
Thank you. This will be the challenge for the process, to make it as easy as possible and flexible as possible to meet all of the settings. Members, any other comments before we go to public comment? Okay, any comment in Sacramento?
Yes, this is Rhonda from Pharmapod again. I just want to say how much I appreciate your consideration for the different ways that folks need to report, because especially, as many people have already said before, PSOs like ourselves also offer a way so that folks don't have to do the duplicate reporting. Pharmacies are extremely busy, and that's not changing. It's only getting worse. So anything that we can do to reduce that reporting burden is in everybody's favor. And it is important so that we can, to reduce that burden, to make sure that we get more people to report, because we know that they're so busy, they're not reporting everything. Not because they don't want to, they just simply don't have time. So I do appreciate your consideration for this. Thank you.
Thank you. Okay, do
No
we
other
have
comments in Sacramento?
Thank you. I think, moderator, we're ready for individuals via WebEx.
All right, our WebEx people, please raise those hands. Dial *3 or hit the hand button. I see we have a written comment as well. Hold on. Our first is going to be Peggy Benzer. Hold on. We're sending you a request to unmute your microphone.
Hi, Peggy Benzer from the Alliance for Quality Improvement in Patient Safety. I just want to say that I think it's wholly important for PSOs to be a reporting entity to aggregate the data prior to reporting for not only efficiency but learning. The PSOs do this under the Patient Safety Act, and the PSOs are actually required to provide individual feedback to help pharmacies solve their own problems. This reporting system, although great, and it's going to be a great learning system, it's one step higher, and so the recommendations would be broader and not individualized, focusing on perhaps class of drugs or some other types of errors and recommendations, but not the individual how to look for problems and then how to solve those individual problems using the individual processes. So I think it's very, very important to continue to encourage the use of the PSOs and not to provide an either or scenario, because that will only hurt the learning system rather than working together to encourage all types of learning. So thank you so much for the opportunity.
Thank you.
All right, next we're going to hear from Stephen Gray. Bear with us just a moment. We're going to send you a request to unmute your microphone.
Thank you again. Yes, I fully support this concept. There needs to be multiple ways that pharmacies can report and report efficiently and in something they can afford. Many systems that were mandated in some cases by government were very expensive to develop, and it really put independent pharmacies, small pharmacies, in a very bad position. The development of reporting systems varied, several 100% from vendor to vendor who was developing your software system for them. So there needs to be plenty of opportunities for pharmacies to choose from. One of the things that I would just mention, I know that some associations were provided a great service by, collaborating with independent pharmacies to jointly fund certain programs to meet government requirements. And this might be one of the ways by number 10 leaves this open for not only individual pharmacies to choose, individual pharmacy owner organizations, but also associations and other entities to help with facilitating the reporting in an efficient manner that helps the board get all of the information it needs, the public to be protected, and also the pharmacies to be protected. Thank you.
Thank you.
That was our last request for number 10.
Thank you. Members, thank you. And thank you to the members of the public. This was a very interesting morning to discuss all of the different issues regarding implementation of AB 1286. We're going to be hearing lots more going on. And if the board agrees, you've delegated the authority to me to work on the panel. I will use the information in our discussions today to work with staff moving forward, and have a couple minutes here if you have any additional comments before we close this agenda item. Members, any final comments? I think everybody's hungry for lunch. So with that, I think it's now 12:30. Let's take a, what do you think, members? 45 minutes, is that enough, or do you need an hour for lunch?
45 minutes is enough for me at least.
Okay, without hearing anything, we'll come back at 1:15 to continue with the rest of the agenda. Enjoy your lunch, everyone.